Check, check, check.
Good morning and welcome back to day 2 of Illuminati. If day 1 was any indication, we're in for another stellar ride. From thought-provoking talks to electric symposiums and a quiz that had our neurons firing, yesterday was a celebration of curiosity, collaboration, and the spirit of research.
We've seen ideas spark, questions fly, and minds meet. And that's exactly what Illuminati is all about.
So, to everyone joining us again, and to those hopping in fresh today, fasten your seatbelts because day 2 is here and it's ready to ignite, illuminate, and innovate all over again.
With this, let's move on to the first event of the day, the finals of Brigadier Vipin Chandra Memorial Pediatric Undergraduate Quiz.
Welcome to a world of tiny patients with big challenges, a world where teddy bears meet textbooks and only the sharpest survive.
However, before starting the quiz, we remember and honor the remarkable legacy of late Brigadier Vipin Chandra. It is both an honor and a heartfelt moment for us today, as we remember and pay tribute to one of the most revered names in Indian pediatrics, Brigadier Vipin Chandra, a distinguished clinician, visionary academician, inspiring teacher, and most importantly, a great human being. Brigadier Vipin Chandra dedicated over 4 decades of his life from 1971 to 2007 to the service of children's health, medical education, and military medicine.
Sir was an alumnus from Medical College Amritsar, did his DCH from Osmania Medical College Hyderabad, and his MD from the prestigious PGI Chandigarh. He also did a diploma in TB and chest diseases from AFMC. His distinguished service as a professor and senior advisor in pediatrics in AFMC, as well as in Command Hospital Southern Command Pune, was marked by an academic excellence, clinical rigor, and mentoring of countless postgraduate students. He served as the commandant of MH Roorkee from 2006 to 2007 before gracefully retiring from the armed forces.
After an illustrious medical tenure, he continued his academic contribution at the Himalayan Institute of Medical Science, Dehradun, where he served as professor and head of pediatrics for nearly a decade. Brigadier Chandra was a recognized postgraduate teacher and examiner for more than a dozen universities, and his research portfolio includes over 60 published papers in national and international indexed peer-reviewed journals.
As a mentor to many, he patiently guided them, teaching pediatrics at the bedside with both expertise and compassion, often going above and beyond to ensure that they were learning and growing. Brigadier Vipin Chandra left for his heavenly abode in August 2024. As a befitting tribute to his enduring legacy, Illuminati is proud to announce the Brigadier Vipin Chandra Memorial Pediatric Undergraduate Quiz.
This quiz will be held annually as a part of Illuminati, and the winners and runners-up will be conferred upon an award in memory of Sir.
May it inspire future generations to follow in his footsteps with the same integrity, compassion, and commitment he exemplified throughout his life.
Moving ahead, we request all the teams to kindly take their seats on the stage. It is a privilege to welcome our quiz master, Colonel Ashutosh Kumar.
Steering today's quiz with clinical sharpness and a neonatologist's precision, we are thrilled to have Sir with us. Sir is a professional professor of pediatrics at AFMC, a national level instructor, and a true champion of quality care.
With a DM from PGI MER and a knack for echo and education alike, who better to quiz our young minds than someone who's seen it all, from NICUs to national podiums.
We now hand over the stage to Sir for further proceedings.
Thank you, Sambhav. Good morning, everyone. I, on behalf of Department of Pediatrics and Illuminati 2025, welcome you all to the first Brigadier Vipin Chandra Memorial UG Pediatric Quiz. We just witnessed the inspiring personality of Brigadier Vipin Chandra. We had a huge response when we announced that we are organizing a quiz in the name of Brigadier Vipin Chandra, and a total of 52 teams all over the country participated in the screening round of the quiz. The best 5 teams were selected after a screening round which was conducted on an online platform. So we have total of 6 teams, 5 teams who have come far and wide to be onto the stage for the final round. We welcome all of you for the quiz and wish you all the very best. We'll request all the teams to introduce themselves, starting from Team A. You can tell your name and the institute from where you have come. Keep sitting and you can...
Hello, good morning everyone. We are from UIMS, Prayagraj, and our name is Ashu Singh.
My name is Shubham Swai. Thank you.
Team B.
Good morning, everyone. We are from Himalayan Institute of Medical Sciences. My name is Vaibhavi Shishodia.
And I am Vardhan. Thank you so much.
Good morning, sir. Good morning, everyone. We are from GMC Nizamabad, Telangana. I'm Surya.
I'm Shishant.
Good morning, everyone. This is Medical Cadet Chaitanya Agrawal and Yash Kashish, Team AFMC.
Team E.
Good morning, everyone. My name is Ishika Awasthi.
Shreya Narwal from SMCW Pune. Thank you.
Yeah. Welcome, everyone. We'll request teams to look onto the screen which is in front of you for the questions. And before you start, we'll have the quiz rules which I would be sharing with you all. So there would be a total of 6 rounds which will encompass the major topics of pediatrics. The first 3 rounds would be from team A to team E, and the next 3 rounds would be from team E to A. Till 4th round, we'll have the chat system where the direct question can be answered by rest of the team, and the 5th round, which would be an audio-visual round where there will not be any passage, or only the team for which the direct question is there will be answering that question. And team 6, the round 6 is the rapid fire round. Regarding the marks, we shall be giving 10 marks if you give the answer correctly in the stipulated time. If the answer given by the direct team is correct, the rest of the team, they don't get any marks for it. If the direct question is not answered correctly by the team, then the rest of the team for whom we have collected the chat, if their answer are correct, they get 5 marks for it. Correct? For the 5th round and 6th round, which is audio visual and the rapid fire, we would be telling you the rules before the round starts. Correct? In the rapid fire, we shall be having 8 questions, which would be within a stipulated period of 60 seconds. You can either answer or you'll have to say skip or pass. You can only reattempt those questions for which you have said pass. Correct? If you have already answered, those questions cannot be reattempted. This is everyone is clear about it, and the decision of the quiz master is final. And amongst us, we have the best of the mind. We have Brigadier Shivendu Roy and Lieutenant Colonel Suprita Kalra. They are the head of the Department of Pediatrics, AFMC and Command Hospital respectively, and they are the jury for the day. Quiz is, it is always said, you never lose. Either you learn or you win. Okay? With this, we move to the question. I hope everyone is ready. Great. So what we'll do, we'll take you to the trial round so that you are very clear that what you are supposed to do. So the team A, this is a trial round. So I'll start with team A. Team A, this is your direct question. So you'll have 10 seconds to answer. So there will be a buzzer which will be displayed onto the screen, and it will play after 10 seconds. So you can answer within 10 seconds. The last answer given by you, whether you give, if you are giving more than one, would be considered as the final answer. And in the same 10 seconds, rest of the team will have to write on the chat. Correct? So the team A, your direct question. You are ready? According to WHO classification for anemia in children, what would be the cutoff hemoglobin for a 12-year-old boy for diagnosis of anemia? Your time starts now.
$11 milligram per dl.
Please collect the checks. So I'll request the volunteer. So team B has written correct. Team D has also written correct. Team E has given the wrong answer, and team C has also given the wrong answer, which means that team B and D would get 5 marks for this round. Correct? I hope it is clear to you all. Okay.
Sir, just a clarification. The team which is answering need not hand over the chit, no?
No, they don't need to hand over. They need to speak during the stipulated period.
Yes. So you don't have to write because
The-
you are answering.
The team for which it is the direct question, you don't need to write the answer on the chat. You are supposed to speak out. And please speak out loudly in the mic so that it is very clear. Okay. So now there have been a little confusion. We'll have one more trial round. Okay? Correct. I hope everyone is comfortable. Oh, not stressed out. Everyone had his breakfast? Great. So moving on to the second trial question. Team B, this is the direct question for you. In the context of a current geopolitical condition and the discussion on Indus Water Treaty that we are discussing, who is the Central Minister for Water under Ministry of Jal Shakti? Your time starts now. Please correct the chat. So the team B has not given the correct answer, so we will be looking at the chats. So all teams are actually very studious, so they don't look at the either news or the YouTube videos that is floating all over the country. So the correct answer is Mr. Shri C.R. Patil is the Jal Shakti Minister. Okay. I hope we are all now ready and tuned up for the quiz. Everyone is ready? So this is round A, consisting of basic sciences, and we start the quiz with team A, your direct question. Are you ready? Yeah. So the direct question for team A, for smooth transition from fetal to neonatal circulation, the various intrauterine shunts needs to be closed. When does the flow through the ductus venosus disappear after birth? Your time starts now.
Within 24 hours.
Please collect the chats. We'll request rest of the participants to please finish it within the 10 seconds. So the correct answer is 7th day. There are various shunts which are functional in the intrauterine period, and those needs to be closed to transition to the neonatal circulation. Unfortunately, none of the team has given the correct answer, so we move on to the next round. The next round is for team, next question is for team B. Team B, are you ready? Yeah. So the direct question for team B. The development of lung is a multi-stage phenomenon starting as a bud. The first stage is embryonic. What is the second stage? Your time starts now.
Saccular.
Please collect the chat. So there are 5 stages of lung development. The first stage is embryonic. The second stage is pseudoglandular. Third is the canalicular. Fourth is saccular, and the fifth is alveolar. Unfortunately, this has not been given correct answer by any of the team. So we move to the next question. Team C, are you ready? Yeah. So for team C, the direct question is, the normal 4-chambered shape of the human heart is achieved by what intrauterine age? Your time starts now.
Three months.
Please collect the chat. The questions are all from your textbook OP Ghai. So the correct answer has been given by team E, which is 6 weeks. So team E gets 5 marks. A big round of applause for team B, because this is the first answer which has been given by the team E. Team D, are you ready? So the direct question to team D is, surfactant is an essential substance which lowers the surface tension within the alveoli, preventing them from collapsing during the expiration. At what period of gestation the surfactant precursor starts appearing on the alveolar lining cells? Your time starts now.
So 32 to 34 weeks.
Please collect the chat. So we all understand the antenatal steroid coverage starts from what period? It is 24 weeks. So team E has given the correct answer. Team E has given correct answer. Team B has given the correct answer. The Team B with Bombay and Team E, Eco, they get 5 marks each for the indirect question. Moving on to the last question of the round. Team E, are you ready? Yeah. So the direct question to Team E is, hematopoietic and endothelial cells are developed from which stem cells? Time starts now.
Multipotent hematopoietic stem cells.
Please collect the set. So the correct answer is, hope everyone has handed over the chat. Yeah. So please try to hand over within the stipulated. The correct answer is hemangioblast. And none of the team has given the correct answer. So this comes to the end of the first round. This was a warm-up round, I would say, for every team. So don't worry, we still have a long way to go. And don't get disheartened if you have not answered the question. Till the time the scorer makes the final score after the first round, we'll have few audience participation and we would be looking at it. So identify the movie, the protagonist, and the disease. Anyone in the audience? So someone please give him a mic.
Duchenne muscular dystrophy.
Oh, he deserves a chocolate. Give him. This is based on a true story of a young chess player, K. Venkatesh, who suffered from DMD and passed away in 2004. So are we ready with the score? Okay, so let's have the score, please. So after round 1, Team E is leading with score of 10. Team C is second with a score of 5. Team A, C, D are still yet to open the account, but there is not much of difference between the scores. So you can come back. There is nothing which has been lost. So moving to the second round, we will be starting again from Team A to E. So Team A, are you ready for your direct question? Yeah. The first question to Team A. What is the chloride concentration in millimoles per liter in a WHO recommended citrate-based ORS? Your time starts now.
65.
So they have given the correct answer, so there is no need for collecting the chats. And a big round of applause for Team A. Team B, are you ready? Yeah. So the direct question to Team B is severe acute malnutrition, SAM. It's a management guideline, is actually a 10-step protocol, and correction of micronutrient deficiency is an important aspect of the care. What is the recommended dose of zinc for the management of SAM? Your time starts now.
10 mg.
Please collect the check. So the correct answer is, everyone has submitted? Yeah. So the correct answer is 2 milligram per kg. Team E has given the correct answer. Team E, Eco, gets 5 marks for it. Team D has given the wrong. Team C has given the wrong answer, and Team A has also given the wrong answer. So the Team E gets 5 marks for the indirect question. Good going. Team C, are you ready for your direct question? Yeah. So Team C, your direct question is, as per IAP chart of BMI, overweight and obesity is based on the cutoff centiles which is there. What is the cutoff centile in a 6-year-old girl to define obesity? Your time starts now. Please collect the
More than 3 standard deviation.
Sorry, the time was done when you... So team E has given correct answer. It's 95 centile. We had asked for a centile cutoffs. And this team D has also given a correct answer of 95 centile. So both the teams, team D and team E, team Delta and team Eco gets 5 marks each for the indirect answer that they have given. So next question is for team D. Team D, are you ready? Yeah. So this is the answer, team D. What is the difference between arm span and length at birth in centimeter?
2.5 centimeter.
So team D gets marks for the correct answer that they have given. The correct answer is 2.5 centimeter. So the team D gets 10 marks for the direct answer. Team E, are you ready? Your direct question is, insulin-like growth factor, IGF-1 and 2, they are important regulators for fetal growth. Name the organ which secretes IGF in fetal life. Your time starts now.
Liver.
Please collect the chits. So the correct answer is placenta. So team D gets a marks for the correct answer that they have given. Team C has also written it correctly as placenta. They get 5 marks. And unfortunately, team A and B, they have written the wrong answer. So after this round, team C and team D, they get 5 marks for the indirect answer there. So a big round for our applause for everyone. They are doing so well. So the scorer, till the time the scorer calculates the score after the round 2, let's have few audience questions. So who all are movie enthusiasts? Amitabh Bachchan is the newly appointed WHO Goodwill Ambassador for a disease, himself being a sufferer of the same. Identify the disease. Give him a mic because he wants a chocolate.
So myasthenia gravis.
So that is also a correct answer, but he is a brand ambassador for actually hepatitis B. He is suffering from myasthenia gravis. Great. So at least identify the actress or the personality. ये हमारे टाइम की हीरोइन है.
So Madhuri Dixit.
Oh, amazing. Chalo. So she is the brand ambassador of a government program. Name the program before you get the chocolate. The chocolate is made of the same thing. So which is the program for which she is the brand ambassador? Okay, no. She is the brand ambassador for a program called MA, which means Mother's Absolute Affection, which is primarily for promotion of breastfeeding. Correct. So, scorer, are we ready with the score? Yeah. So, after round 2, there is a tie between team D and team E. Come on. So team D and team E, they have the score of 20, followed by team A with not far behind, at score of 10, and we have team B and C, they are at score of 5 each. Come on, team B and C. Yeah. So the third round, this round will be also from team A to E, and we'll have the first direct question for team A. Team A, are you ready? So this is primarily a neonatology round. So team A, your direct question is, Downey score is used for assessment of respiratory distress in a neonate. The score utilizes 5 parameters, which is respiratory rate, cyanosis, grunting, retraction. What is the 5th parameter which is being assessed? Your time starts now.
Heart rate.
Please collect the chit. So I'll request rest of the team to please finish writing within the 10 seconds. So the correct answer is air entry that we look for. So team E has given the correct answer. Team C, wrong answer, they have written pulse. Team B, nasal flaring, which is wrong. Team D is appearance, which is wrong. So which means team E, gets 5 marks for the incorrect answer. Team B, your direct question, are you ready? Yeah. A preterm neonate is one who is born less than 37 weeks period of gestation. The prematurity period has been subdivided into various subdivisions. Who is called a very preterm neonate? Your time starts now.
Less than 28 weeks.
Please collect the chits. So the correct answer is 28 weeks to 31 plus 6. Team D has given the right answer. Team E, Team A has given the wrong answer. Team C has given the right answer. We would give to them. Team E, I don't know, they have written 28 to 32 weeks and then they have written 3 down below. Okay, so we give the marks to them. So team E, team D and team C, they get 5 marks for the indirect answer that they are given. Please be clear what you write on the chat. Team D, are you ready? Your direct question is, sorry. So this is the team C direct question. Which type of neonatal seizures carry the worst prognosis? Your time starts now.
Focal seizures.
Please collect the chat. So we have team B and team D and team E. They have given the correct answer, and the correct answer is myoclonic seizures. The myoclonic jerks carries the worst prognosis, and the best prognosis is with late onset hypocalcemia. So team D, are you ready for your direct question? Yeah. So moving to team D, antenatal corticosteroid use is a proven intervention to improve the preterm birth outcomes with benefit and reduction of multiple morbidities like respiratory distress, NEC. What is the contraindication for using antenatal corticosteroid? Your time starts now.
Congenital adrenal hyperplasia.
Please collect the chat. So the correct answer is frank chorioamnitis, and I would give it to team E. They have written chorioamnitis. So team E gets 5 marks for the indirect question. Team E, are you ready for your direct question? Yeah. So we have Levin's classification for hypoxic ischemic encephalopathy staging, which includes 4 parameters to classify into mild, moderate, and severe encephalopathy. The 3 components are consciousness, suckling, respiration, and seizures. What is the 4th component? Your time starts now.
EEG findings.
Please collect the chits. So we have collected the chits. So the correct answer is basically tone. Team B has given the correct answer. Team D has written EEG, which is wrong. Team A has written lethargy, which is wrong. So team B, Bombay, gets 5 marks for the indirect answer. So this brings us to the end of the 3 rounds. Till the time we have the score the fight is still on. We are just halfway through. So the team who are actually not lagging, they are just a small step behind. You all can come back again and fight it out. So till the time the scorer is making the report, the scorecard, we'll have one audience question. This was death of John Kennedy's newborn, which was due to a particular disease the newborn suffered. The newborn survived for precisely 39 hours, and this was in August 1963. Can someone tell me the disease? Because this was the beginning of neonatology, and from there the research was funded. So anyone from the audience? So Gitanjali gets though this is not applicable for Gitanjali, so Gitanjali gets a chocolate for it. The answer is this was hyaline membrane disease, or what we call respiratory distress syndrome. And after the death of the president newborn, the funding started coming up for neonatal researches, and thereafter we were able to have the CPAP, the surfactant, which was being developed. Now, continuing the same thing, if we look at this logo, this is what? So this is Scientific Society meeting. So this is what? This is the logo of the Cochrane collaboration, correct? So Cochrane is what? Basically, they are coming out with the systematic review. What is the, what does the logo of Cochrane collaboration represent? So onto the right of your screen, you can see a blue logo where we can see 2C, and there is a round circle within which we have lines and the diamond which is there.
Sir, it is a systematic review done to see the effect of corticosteroids in premature.
So she deserves a double chocolate from our side, because this is the logo, because this was the first systematic review, and they realized this was the iconic study wherein the role or the benefit of antenatal steroid given to the mother was shown in the newborn period, where they had multiple reduction in various morbidities. And we had one of the questions during our rounds. Very excellent. The 2C represent basically the collaboration that we have. Okay. Are we ready with this score? Yeah. So after round 3, which is halfway through, Team E is leading with score of 40 marks. Team D is just behind with score of 30, and we have a tie between Team A, B, and C. They are at 10 marks. Okay. So from this round onwards, we'll have a Team E to A as the sequence of event, and the first question to Team E. Are you ready for your direct question? Yeah. So the direct question for Team E. This is a systemic round, so please read it very carefully and then only answer. Team E, your direct question is, a 3-month-old female infant presented with persistent cholestatic jaundice, failure to thrive, and abdominal distension. Examination revealed posterior embryotoxin, pulmonary stenosis, and radiograph spine revealed butterfly vertebrae. Identify the medical condition. Your time starts now.
Oncology syndrome.
So they deserve a huge round of applause, and this is the correct answer which they have given. So this is Oncology syndrome, where we have congenital heart disease, characteristic finding in the facial appearance, and a characteristic radiographic finding. Great. So coming to the Team B, are you ready for your direct question? Team D, the direct question to you is, this is a 7-year-old female who has been brought with complaints of gradually progressive distal muscle weakness and wasting with difficulty in opening the hand after making a fist. The clinical features revealed a characteristic elongated facies and an open downturn mouth with dental malocclusion, which we can see in the photograph. The investigation revealed CPK of 513 unit per liter, and the EMG has characteristic revving engine sound. What is the likely diagnosis? Your time starts now.
Sir, myotonic dystrophy.
So I can 4C, the great clinician in making. The answer has been given is correct. It's myotonic dystrophy. So amazing. So the team D gets 10 marks for the correct answer. Team C, are you ready for your direct question? Team C, your direct question is, a 5-year-old boy with bilateral flank mass with oliguria, hypertension, and has got presented to us with hematemesis. Ultrasound abdomen revealed bilateral enlarged bright kidneys. There were multiple cystic lesions in the liver associated with intrahepatic bile duct dilatation. What is the most likely diagnosis? Your time starts now.
Horseshoe kidney.
Please collect the check. So the correct answer is autosomal recessive polycystic kidney disease. And team E has given the correct answer, team ECO. Team D has written polycystic kidney disease. Should we give it to them? Okay, so team D gets 5. Team B also gets 5 marks. Team A also gets 5 marks. So all the 4 teams has got 5 marks each, less team C, who were facing the direct question. So autosomal recessive polykidney disease, basically it's an inherited malformation where there is a problem with the renal cortical collectance system, and along with we have the liver involvement which is there. Okay, so moving to the next question for team B. Team B, are you ready for your direct question? Yeah. So this was a 14-year-old girl with 1-year history of episodes of recurrent abdominal pain and vomiting. She started to have behavioral changes. Her clinical examination, when she reported, had tachycardia. There was no organomegaly, guarding or rigidity per abdomen. Her urine color changed on standing, which can be seen onto the screen. What is the most likely diagnosis? Your time starts now.
Phenylketonuria.
Speak loudly.
Phenylketonuria.
Please collect the checks. Please try to give your checks within the time. So the correct answer is acute porphyria. So the team E has written porphyria. We give it to them 5 marks. Team D has also written porphyria. They get 5 marks. Team C has written alkaptonuria, which is a wrong answer, and Team A has written intussusception, which is a wrong answer. So after this, Team D and Team E, they get 5 marks for the indirect answer. Okay, moving on to the next, the last question of the round. Team A, are you ready for it? Yeah. So the Team A, the direct question is, we have a 9-month-old male infant with generalized hypotonia, muscular weakness, macroglossia, and hepatomegaly. The chest X-ray revealed cardiomegaly. The ECG, which is characteristically seen onto the screen, had left axis deviation, a short PR interval, and a large QRS. What is the likely diagnosis? Your time starts now. Chits have been collected? Yeah. So the correct answer is Pompey's disease. Team D has written correct. Team E has not responded. Team B, congenital hypothyroidism, which is a wrong answer. So this is a glycogen storage disorder, which is because of the deficiency of enzyme alpha-glucosidase. And we have cardiac involvement with a tone abnormality, which was reflected. I'm so happy and proud to see most of you people answering all the questions, at least attempting everyone. So after the round 4, till the time we have the score, let us have 1 or 2 questions. For this round, Team D got the 5 marks. Gaurav, for the last question, Team D got 5 marks as the correct answer. Yeah. So this movie, which came in 1992, all those movie enthusiasts, this portrays the plight of the parents of a young boy suffering from a neurodegenerative disease and the journey to finding a cure. What disease was the child suffering from? Answer is there on the screen also. So there is a clue to the answer. It's a neurodegenerative disorder. Okay. So okay, you get a chocolate from our side. So the correct answer is adrenoleukodystrophy. Chalo, next. So still some time left. So this was a 2008 documentary film which won the Academy Award for the best documentary. The movie profiles a poor girl from rural India whose life gets transformed by a special program that offers free cleft lip and palate surgery. Name the movie, and the movie itself will tell you about the program. Which was this movie? Oh, yeah, so she gets a chocolate for it. It was Smile Pinky, and the program is Smile actually. So where they give free cleft lip and cleft palate. So are we ready with this course? So after round 4, we have team E, which is still leading with a score of 60, with a just behind score of 55 of team D. So they are neck to neck actually. And we have team A, B and C. Team A and B with score of 15 each, and the team C is at score of 10. So this was till round 4. Now round 5 is a audio visual round, and the rules I will reiterate again. This round will have 2 parts of the question, correct? So you need to answer the first part, which is generally will be a identification of the either an image or a figure, whatever it is, and answer, or after the identification, the part 2 will be reflected. So you need to answer the part 2 thereafter. If you answer both the parts correctly, you get total of 10 marks. And unless you have answered the first part, you will not have the luxury to get to the second part of the question, correct? So I hope everyone is clear on this account, and will not be collecting any chit during this round. So we'll have direct questions starting from team E. Okay, so team E, are you ready? This is a 5-year-old male child with obesity and intellectual disability. The characteristic clinical features and fundoscopy are as follows. What is the fundoscopy finding? Your time starts now.
Retinitis pigmentosa.
So they have given the correct answer, and I can declare it because, so moving on to the second part of the question. So it is retinitis pigmentosa. Very good, great. So what is the likely diagnosis?
Lawrence Moon Beetle Bardet.
Oh, great. So they have given the second part of this is Bardet Beetle or a Lawrence Moon Beetle syndrome. So the team E gets 10 marks for answering both the parts correctly. Team D, are you ready? Yeah. 3-month-old infant with history of prolonged jaundice in neonatal period. Clinical findings revealed coarse skin, has got protuberant abdomen and umbilical hernia. Identify the abnormal X-ray finding. Your time starts now. Whatever you can see in the X-ray.
So patella is absent.
Oh, we cannot give you the, this is basically the absence of the femoral epiphysis. And what was the disease that we were presenting? So anyone can say? Now that it has become, any audience or any other team? Yeah, so it was a congenital hypothyroidism with absent. So we cannot give you the answer. Should we flash? We cannot. Okay. So this was the absence of femoral epiphysis. Here we can see a normal X-ray, how it would have been seen. Now, the part 2 is, what is the commonest cause of congenital hypothyroidism? This is the audience question now. Okay, so the answer is thyroid dysgenesis. Okay. Team C, are you ready? Your direct question is, A 3.5-year-old male child presented with cyanosis, exertional dyspnea since infancy. His SpO2 in room air was 85 to 90%. Child has S2 split which was wide and fixed. Identify the characteristic pattern or configuration of heart in this chest X-ray. Your time starts now.
3 sign. Figure of 3 sign.
So the correct answer is snowman or figure of 8 configuration. So this is seen in which condition?
Total anomalous pulmonary.
So it's a supracardiac TAPVC that we see. Coming to the part 2 of the question, what is the earliest age beyond which this characteristic X-ray finding can be seen? This is an audience question now. So any of the team which can answer, you'll not get a marks, but anyone wants to attempt it? So this can be seen only after 2 years of age. Okay. So team B, your direct question is, this is an 18-month-old toddler who presented with irritability and painful limb. He has got following characteristic clinical and X-ray finding which is there onto the screen. Identify the abnormality which is marked by the arrow. So your time starts now.
Rachitic rosary.
Speak clearly.
Rachitic rosary.
So you missed looking at the X-ray and the clinical profile that we present. So this is classical vitamin C scorbutic rosary where we have the Wimberger's sign and the characteristic pattern of that. So the audience question, name the enzyme required for conversion of glucose to ascorbic acid, because we all lack this enzyme and thereafter, and that is the reason we need to. Answer is, it's the gluconolactone oxidase. We all humans lack this enzyme and that is the reason we all need to take vitamin C. Okay. So moving on to the last question of the round, team A. So you are ready? This is a 6-month-old infant with motor delay and repeated chest infection. Identify the tongue finding. Your time starts now.
Sir, pulsatile tongue.
So pulsatile is a common lay term. The technical term is a tongue fasciculation. And so what is the condition? Name the FDA approved oral drug which is used for therapy of SMA, because this is the SMA which we are seeing. So which is the drug? Audience round. This is audience question. So it is all from your textbook OP Ghai. So risdiplam is the oral drug which is FDA approved for the treatment of SDA. So we have this score after the 5th round. So we are left with one rapid fire round which is a very scoring round. So please be attentive and you can score and change this final score as well. So before we have the score after the round, we'll have few audience questions. In 1975, it was first presented by Ray and Martin in Bogota, Colombia, where it was developed as an alternative to inadequate and insufficient incubator care for those preterm newborns who had overcome initial problems and required only to feed and grow. So what we are talking about, what was the discoveries which was happening at that point of time? So I can see 2 hands up. So you can speak without mic, speak loudly. Okay, so give 2 chocolates to both of them. So this is what we talk about kangaroo mother care, which is a skin-to-skin contact for a growing baby, which has been found to improve the outcome for a newborn, both in terms of mortality benefit as well as multiple morbidity improvement, which has been seen. So are we ready with the score? Yeah, so can we have the score? So after round 5, team E is leading with a score of 70 Team D is next, neck to neck with score of 50. Team A and B, they are at score of 15 each, and we have Team C with score of 10. So this is a big round for applause for everyone. Great. So coming to the final round of the quiz, which would be a rapid fire round, and I would be reiterating the rules once again. So this round has got 8 questions, which would be, and we have 1 minute for it. 5 marks should be given per question if you answer it correctly. You can either answer the question or say pass, or you can, which means you can skip the question. The question which has been skipped can only be re-attempted within the stipulated time of 60 seconds. All those questions which you have already answered will not be accepted for a second attempt. So I hope everyone is clear for the round. So we'll start from Team E to Team A. So Team E, are you ready?
Yes.
Team E, your time starts now. As per NRP 2020, resuscitation in preterm neonate started with how much FiO2? Say pass or answer.
20 to 31%. 21 to 30.
Name the enzyme deficient in Tay-Sachs disease.
Hexosaminidase A.
Stipple sign on neck X-ray is suggestive of which disease?
Laryngotracheobronchitis.
What is the upper age limit for attaining visual fixation?
2 years. 2
Name
months,
an-
2 months.
Name any 5th generation cephalosporin. As per IMNC, umbilical pus discharge is a sign of possible serious bacterial infection. True or false?
True.
False.
Strain used for preparation of live attenuated JE vaccine is?
SA1441.
Expand the acronym PANDAS.
Pediatric autoimmune neuropsychiatric disorders associated with streptococcal.
So you are left, you have passed one question, or the time is over. Yeah. So the correct answer, what they have given is, as per NRP 2020, resuscitation in preterm neonate started with how much FiO2? The answer is 21 to 30%. The enzyme deficient, they said it correct, hexosaminidase. Stipple sign is group, which is LTB. Upper age limit is 2 months. They did not answer the 5th question, and 6th, 7th, and 8th, they gave it. 6th was wrong, 7th was wrong, and 8th was correct. Okay. So for the question number 4, they had said 2 years first, so they don't get the marks for it. So they have given 4 answers correct, which is 1. So we should accept. Okay, so they get 5 marks for that also. So they have total of 5 answers which was correct for them.
False also the last one.
So they are saying that they said false also in the IMNCI question, which is as per. Okay, so the team E gets. Okay.
6 correct. 6 correct answers.
Okay, team B, are you ready for your rapid fire? Your time starts now. As per NRP 2020, MR SOPA is the ventilatory corrective step. What does R stand for?
Readjusting head position.
Name the enzyme deficient in classical homocystinuria.
Cystathione beta synthase.
Thumb sign on neck X-ray suggestive of?
Pass.
What is the upper age limit for attaining sitting without support?
10 months.
Name the antidote for accidental overdose of beta blocker.
Glucagon.
As per MNC, less than 90%. What is the route of administration of
Intradermal.
Expand the acronym IYCF.
Pass.
So you can reattempt IYCF and thumb sign.
Glossitis, acute glossitis.
IYCF? Okay. So they have given 6 correct answer and the 2 answer that's wrong. So they get 30 marks out of this round. Team C, are you ready for the rapid fire? Yeah.
Yes, sir.
So this is the correct answer which we have already discussed. Now coming to Team C, are you ready for your rapid fire? Yeah. So your time starts now. As per NRP, what is the target SpO2 at 5 minutes of life?
Pass.
Name the enzyme deficient in Krabbe's disease.
Pass.
Claw sign in Barian enema is seen in. What is the upper age limit for attaining walking without support?
10 months.
Antidote for opioid overdoses.
Naloxone.
As per IMNCI, child has persistent diarrhea if it lasts more than 7
False.
days. What is the route of administration of live at Japanese encephalitis vaccine?
Anterolateral aspect of thigh.
Subcutaneous.
Expand the acronym NBSU.
Newborn Stabilization Unit.
So you can answer the past question, which is claw sign.
Pyloric stenosis.
And the first and 2, which is as per NRP, what is the target SpO2? You can attempt.
170.
So the correct answer is, as per NRP, the target SpO2 is 80 to 85%, and the enzyme deficient in Krabbe's disease is galactocerebrosidase. The wrong answer which was given by them was question number 4, what is the upper age limit for attaining walking without support? So they have got total of 4 correct, and they get 20 marks out of this round. Moving on to the next, Team B. So Team B, you are ready? Yeah. So the time starts now. As per NRP 2020, after 30 seconds of effective PPV, if the heart rate is 80 beats per minute, what is the next step?
Chest compressions.
Name the enzyme deficient in GSD type 0. Donut sign on USG abdomen.
Glucose 6 phosphatase. Second one.
Donut sign on USG abdomen is characteristic of.
Pass.
Interception. Interception.
What is the upper age limit for attaining
9
speed?
months.
Name the antidote for carbon monoxide poisoning. As per IMNCI, fever is defined as temperature of more than 37.5 degrees centigrade.
True.
What should be the minimum gap between PCV 13 and PPSV 23 administration?
3 months.
Expand the acronym SNCU.
Special newborn care unit.
Say it again.
Special newborn care
Yeah.
unit.
So you can reattempt. Yeah, the time is over. So the question which they didn't attempt it was the antidote for carbon monoxide, which is oxygen. So the first is you have to continue PPV because its a heart rate is more than 60. So you don't give chest compression. Correct? Okay. So they have given total of 3 correct answer, which fetches them 15 marks out of this round. So the last rapid fire round for Team A. Team A, are you ready? Time starts now. As per NRP 2020, what is the formula for ET tube insertion depth? Which enzyme activity is decreased in maple syrup urine disease? Lemon and banana sign are seen in which disease on antenatal scan?
Pass.
What is the upper age limit for attaining imaginative play?
6 months.
Wrong. Name the antidote for benzodiazepine poisoning.
Pass.
As per IMNCI, a 3-year-old child with diarrhea with sunken eyes and irritability is classified as severe. As per UIP, the catch-up age for first dose of rotavirus vaccine is. Expand the acronym JSSK.
जननी शिशु सुरक्षा कार्यक्रम.
So you can re-attempt question number 1, 2, 3. So the correct answer is, as per NRP, the formula for depth calculation is NTL plus 1. The enzyme is branch chain alpha keto acid dehydrogenase. Lemon and banana sign is seen in neural tube defects. The imaginative play is seen by 3 years, and rest you said correctly. The last 7th question you didn't attempt it. It is 1 year as per UIP. Okay. How many correct? 2. So they have given 2 correct answer, and they get 20 marks for it. So this brings us to the end of the quiz. Till the time we have the final score after the 6 rounds, we'll request everyone to give them a big round of applause, because the way they have answered for the last 6 rounds is absolutely commendable. As an undergraduate student, if the way they have been answering, especially the clinical round, it speaks a volume about the training that they are getting in their respective colleges. So let's have the final audience question. Again, this movie is based on the true story of a rare genetic disorder where there was an attempt to develop a therapy for the same. Name the genetic disease which is being targeted in this movie, and is the treatment available yet? Bolo?
Sir, Pompey's disease.
Oh, he gets a chocolate for it. So it's a glycogen storage disease, it's the Pompey's disease, and we have the enzyme replacement therapy which is available with us. Okay, so do we have the final score, Gaurav? So this is the final score, and we have Team A with a score of 30 marks. A big round of applause for United Institute of Medical Sciences, Prayagraj. They have come all the way from Allahabad to participate for the quiz. We have Team B and C. Team B is Himalayan Institute of Medical Sciences, Dehradun. We have Team C from Hyderabad, Telangana. And the score of both Team B and C is 30. We have Team D, AFMC, with a score of 85. And the winner for today's quiz is Team E, which has scored 100, and they're a true winner for the quiz. So a big round of applause for everyone. And congratulations to all the team for coming all the way far and wide to this place for participating in Illuminati and in the quiz. So congratulations everyone. No one is a loser actually. So you all participated. That's a great achievement for you all. I would like to thank everyone, especially Brigadier Shwendu Roy and the entire team of pediatric, without whose support or with this quiz wouldn't have been possible for me to be conducted the way we have done it today. And special thanks to all the great cadets who have been a source of inspiration, and the way they have been answering the audience question. Actually, they need to see more movies, I suppose. So they know. So thank you everyone for this. We'll request Brigadier Suvendi to come onto the stage so that we have a group photograph for the event. And the prize ceremony, wherein the cash prize, the certificate and the memento would be handed over during the valedictory central function, which is at 2:30 in the afternoon. So we'll request the team to be there for the presentation part. Can I have the lights, please? Stage lights. We'll request teams to move forward so that we have the group photograph. Thank you, sir. Thank you, sir. Khatam. अरे
डिस्कनेक्ट हो गया।
check, check. Check, check. Check, check.
A very good morning to one and all. Before we could start the event, can I just know if all the presenters are present here? Antara Agarwal, Shinde Shankar Satish, Sharayu Sunil Indurkar, Bilha and Chiki, Swastika Mandal. Thank you. May we start, sir?
We now move on to the next event, the finals of Incendium, our paper and poster presentation, where ideas don't just spark, they catch fire. As our paper and poster presentation finals are in full swing, the air is practically crackling with innovation.
From bold hypotheses to breakthrough findings, this is where the future of medicine is getting written. One poster, one paper, and one passionate presenter at a time. In true Illuminati style, let the flames of discovery burn bright, because brilliance looks best under a spotlight.
On this note, let's welcome our chairs for today. Joining us as the chair for Incendium, a true pioneer in the world of orthopedics, Brigadier B. Hari Krishnan.
From serving on the front lines in J&K and Siachen to performing the first hip arthroscopy in the armed forces, his journey blends battlefield grit with academic brilliance. With over 15 publications, international recognition in Nature Reviews Rheumatology, and groundbreaking work in osteoarthritis research, he brings both precision and passion to the table.
It's truly an honor for us to have him spark the flame of inquiry at our paper and poster finals.
Our next chair is a stalwart in the field of geriatrics, professor in HOD, Department of Geriatrics, and editor-in-chief of the medical journal Armed Forces India, Colonel Vivek Agarwal.
Sir brings both academic gravitas and a keen eye for research. With over 45 publications, national awards, and expertise spanning fertility to dementia, we're honored to have him help ignite the flame of discovery in today's paper and poster finals. With this, we now hand over the proceedings to the chairs.
Good morning, ladies and gentlemen. A warm welcome to you all to Armed Forces Medical College, Pune. Let me, without wasting much time, introduce you to our illustrious judges for today's event. The first judge is Brigadier Kunal Chatterjee. He is my senior colleague, alumnus of AFMC Pune, both MBBS and MD. He is a postgraduate diploma in disaster preparedness and rehabilitation from Indraprastha University, postgraduate diploma in health economics, healthcare financing and policy, and he's received Vice Chief of Army Staff Commendation in 2008 for his illustrious service. He is a true academician with numerous achievements and expertise. He has attended the World Health Organization Fellowship in Field Epidemiology at National Institute of Communicable Diseases at New Delhi, Health Policy and Advocacy at University of Indonesia, and a membership of IPHA, IAPSM, and ISMOCD.
Yeah, our next judge is Brigadier Sri Satish. Sir is a surgeon and an innovator. Sir has done his MBBS from RGHS, and following which he did MSc in Biomedical Engineering from University of Surrey in UK. He is specializedly trained in prosthetic surgery from Queen's Mary Hospital in Roehampton, and he has played key roles in the various hospitals to establish a department of prosthetics. He has been a former commandant of a very busy operational hospital of 150 General Hospital, and presently he is commanding Artificial Limb Center, which is the oldest center in India, which provides limbs to our soldiers and the veterans.
Coming next to the next judge, Dr. Seema Patrikar. I'll be very honest with you all that from my MBBS days in this college to my post-graduation and thereafter my role as a teacher in this college as assistant professor, associate professor, as well as professor HOD now, I have seen this smart academician and exemplary teacher. She's been my teacher. I was very poor in statistics, and she has taught me and played a very important role in grooming me also. She's one of the judges here. She's an academic leader, statistician, and public health expert. She's a PhD in economics, MSc in statistics, and master's in population studies. She's a diploma in business management and IT. She's a senior lecturer and associate professor of Medical Journal Armed Forces India. She played a key role in COVID-19 Task Force and NHSRC Standing Research Committee member. She has received the Vice Chief of Army Staff Commendation Card in 2019, DG AFMS Award in 2015, Chief of Naval Staff Award, and a World Health Organization Fellowship. She's had numerous publications, more than 100 publications with H-index of 17. She's a national and WHO project contributor, and recently she's won the second best winner in Sangam 2023 IIT Powai. She's a voice of clinical research and applied statistics excellence, and we are proud to have her as one of our judges. Thank you, ma'am.
Okay, now coming to the rules of this session. So there was a round which was conducted yesterday. It was a preliminary round, and total of 72 delegates presented across 6 different verticals, namely clinical sciences, preclinical sciences, behavioral sciences, public health sciences, pharmacology and diagnostics, and interdisciplinary. Out of this, top 7 presenters across all the verticals have been selected for the finals today. And participants will be given total 7 minutes to present, followed by a Q&A of around 3 minutes. A warning bell will be rung at 6 minutes and 30 seconds, and final bell at 7 minutes. And negative marking will be done if the delegate exceeds the time limit. So the order of presenters are: first will be Antara Agarwal, second will be Shinde Shankar Satish, third will be Sarayu Sunil Indukar, then Bihla and Jiki, Swastika Mandal, Ruprika Pila, and Celine Raffil. So I request first presenter, Antara Agarwal, to come and present the. Starts the once she starts speaking. Okay, thank you.
Either consumes a substance on the screen or knows someone who does. And in the past few decades, alcohol consumption has only been on a rising trend, with almost 30% of our countrymen consuming some form of liquor. We're all well versed with the concept of alcoholic hepatitis, a common consequence of prolonged alcohol use. And while early management can cause cure and even reversal of this disease, most patients in our country, unfortunately, present at late stages and cannot be saved, leading to deaths not just in our country, but globally, with more than 2.5 million deaths occurring worldwide due to alcohol liver disease alone. And these figures keep rising every year, despite advancement in treatment. Thus, it is imperative that we develop good markers for prognostication as well as to tailor management. Many prognostic markers exist, notably the model for end-stage liver disease. However, these traditional non-invasive markers may not always be sensitive and can also be inconclusive. A few studies have proposed the use of liver biopsy as potential prognostic tool for alcoholic hepatitis, while a few others have speculated the value of hepatic venous pressure in the disease prognosis. For the first time in India, our study combines these parameters and aims to investigate the prognostic utility of histological scoring and hepatic venous pressure gradient measurements, along with non-invasive markers in patients diagnosed with severe alcoholic hepatitis. Our study was a 2-year-long prospective study, including patients with clinically defined severe alcoholic hepatitis. Patients who were chronic alcohol abusers had abnormal liver enzymes and bilirubin levels were included, while those with coexisting liver pathologies and active infections were not taken in. The patient's prognostic scores like the MELD, MDF, GAHS, and ABIC were calculated. And as patients with severe alcoholic hepatitis may have coagulopathy, percutaneous biopsy approach could pose a risk for complications like uncontrolled bleeding. Hence, transjugular liver biopsy was performed instead. This also helped in the simultaneous measurement of hepatic venous pressure gradient in the same setting. The biopsy was evaluated using the alcoholic hepatitis histological score. The patients were assigned an AHSS score based on their findings of fibrosis, bilirubinostasis, PMN infiltration, and megamitochondria, and then classified into mild, moderate, and severe based on their points. The patients were followed up, and the survivor scores were recalculated at day 30, while the investigations done just before the demise of the non-survivors were evaluated. Our results showed that out of the 45 people sampled, 21 patients survived, while 24 didn't. And the amount, duration of alcohol, and the age of the patient was significantly higher in non-survivors. The biochemical parameters, like the international normalized ratio and bilirubin levels, were notably worse in non-survivors. Along with that, all prognostic scores were significantly higher in the patients who passed away. A key result was the noteworthy higher value of the alcoholic hepatitis histological score, which indicates a strong correlation of histology with prognosis. However, the same was not seen with hepatic venous pressure gradient, which showed no significant correlation with short-term mortality. While non-invasive markers have been widely used to assess the severity of alcoholic hepatitis, concerns have been raised on their accuracy, reproducibility, and sensitivity. Out of the traditional markers, the model for end-stage liver disease has the highest predictive value. Our study shows that alcoholic hepatitis score proves to be predictive and more sensitive even when the MELD scores are low to moderate or inconclusive. AHHS thus can successfully identify a patient with poor histological profile even when lab values underestimate disease severity. Our study is pioneering as it is the first Indian study integrating liver histology, hemodynamics, and biochemical scoring in the prognostication of patients with alcoholic hepatitis. And this is the first time this score has been applied and evaluated in Indian population. This is pivotal as histological score will not just help in precise prediction of short-term mortality, but will identify patients needing aggressive therapy and aid in efficient management. A pre-treatment histological report will identify candidates for steroid therapy, which forms a mainstay for treatment of severe alcoholic hepatitis, and also importantly rule out patients with latent or hidden liver pathology like viral hepatitis, which may in fact worsen with steroid therapy. Severe alcoholic hepatitis has high mortality rates and is a serious problem plaguing our country. Our study could provide a stepping stone for validation in larger diverse populations, and eventually may even lead to the integration of histological scores in the standard protocols for prognosis and management of serious stages of this serious disease. A quick diagnosis and a smart prognosis are not the end, but the beginning of good practice, and our journey towards quickly and smartly saving the Indian liver from the wrath of alcohol has just begun. Because is life worth living? It all depends on the liver. Thank you so much.
They can be asked, yes.
Yes, Dr. Antara, I think I'm audible. Am I audible?
Yes, ma'am.
Very good presentation.
Thank you, ma'am.
I just have two queries to you. One is, how did you select these patients? 45 patients, were they formally being calculated, and how did you select them?
Ma'am, the patients who came to the hospital with alcoholic hepatitis were identified, and those patients who met our inclusion criteria of having severe alcoholic hepatitis, like a MADRS discriminant function of more than 32, or raised bilirubin levels, or an AST by ALT ratio of more than 1.5 were chosen, as they were good candidates for this study. And those patients who had coexisting liver diseases were excluded, as they could have confounded the results of the study.
So the random sampling method was used?
Yes, ma'am.
And was the sample size formally calculated?
Yes, ma'am. By n was equal to PQ square, 4 PQ upon L square.
Since you have found out about this particular methodology, what do you think, in your opinion, would be the right time to, administer this score so that you get a desired result? Okay. Very generally, I want to know. I'm sure this is not a very specific thing which I'm asking. Very generally, what do you think would be a right time to administer this score?
Thank you, sir. Sir, I believe that patients who have very classical textbook presentations of a typical AST by ALT ratio, raised bilirubin levels, a typical clinical presentation of alcoholic hepatitis, and a clear history of prolonged alcohol abuse may not fit the criteria. But patients who have an inconclusive or borderline prognostic scores, where their MELD and MDF scores aren't very reassuring for us, or if there's a discrepancy between their lab parameters and clinical presentations, where we need a better prognostic insight into how to manage the patient, we will have to take this approach. So I would like to call this a selective biopsy approach, where we won't subject all patients to biopsy, but those where we feel the non-invasive markers may not be sufficient enough to help prognosticate the patients, we will employ this method. As I understand that this is an invasive procedure and can also pose the risk of complications like uncontrolled bleeding and infection and abdominal pain. We must be judicious in our use of this methodology, but it is important to keep this in our armamentarium for prognosis, as if we don't identify patients on time and don't understand the need for aggressive treatment, it may lead to the death of these patients because of inefficient and late onset treatment.
Okay, thank you.
You said you included cases of alcoholic hepatitis here. And so how do you read the diagnosis of alcoholic hepatitis? I mean, patient does not come with a presentation saying, I have alcoholic hepatitis.
Sorry, sir?
No, you said your inclusion criteria, you included cases of alcoholic hepatitis. So were they already diagnosed as alcoholic hepatitis?
So the patients who came to us with, for example, with icteric presentations, abdominal pain, or for some other reasons, who were identified as alcoholic hepatitis patients upon calculation of their lab parameters, were taken into the consideration for inclusion in the study. So they did not come as patients of alcoholic hepatitis, but they must have come with a menagerie of symptoms, and on clinical diagnosis, they were considered for inclusion in the study.
Okay. Any complications with the invasive procedures? Rate of complications?
Yes, sir. So this study, this procedure does involve the complications like if there is perforation of the peritoneum, or if there is perforation
no, in your study, did you have any complications? What was the rate of complications? How many of the patients? I mean, you said you had 45 patients.
Yes, there were 45 patients, sir, and 21 of them survived and 24 sadly passed away, sir. So there was a little problem in calculation of the accurate results for following up these patients because of attrition rates. And also out of 45, 2 patients, biopsies could not be performed successfully.
Okay, so just one small question. How many patients had concomitant cirrhosis along with hepatitis? And how did you contribute to this research?
Sir, out of the 45 patients, amongst the 21 patients who survived, 7 of them had cirrhosis, and out of the 24 who died, 18 had cirrhosis. And sir, I helped in the data collection and analysis, and also with the writing of the study, sir.
Okay, thank you.
Thank you so much. Thank you, ma'am. Thank you, sir.
Okay, the next presenter is Sanskar Satish Shinde.
Today I am going to present a systematic review of role of microvascular free flap in maxillofacial wall injuries. The maxillofacial wall injuries are most destructive injuries among battlefields. It severely destruct the face and impair vital functions such as breathing, speaking, swallowing, and it may also impact the quality of life of the patient. The microvascular free flap is the modern surgery which can restore the form and function of the whole maxillofacial area. These techniques helps to transfer the healthy tissue from donor side to the reconstruct the face and restore the form and function. These are the commonly used free flap we most commonly use apart from other free flaps because of their more advantages. They are radial forearm flap, rectus abdominis flap, anterolateral thigh flap, and fibular flap. These are the surgical planning and techniques we use for higher success rate. Firstly, we divided into 3 parts. pre-operative planning, intraoperative techniques, and post-operative management. In pre-operative planning, we firstly virtual surgical planning should be done for the precise surgery. Then we select the flap according to the location and extent of the lesion or wound. Then in intraoperative techniques, we first do debridement and stabilization. Then we harvest the flap from the donor site and insert on the wound area. Then we do microvascular anastomosis. In a post-operative management, we do flap monitoring hourly to prevent infection. And then we give functional rehabilitation, and we also manage the complications. In the post-operative care, we firstly do immediate monitoring such as flap perfusion by Doppler trace for 24 to 48 hours every hourly. Then we check vital signs, particularly mean arterial pressure, which should be greater than 65 mmHg. And then we do infection and complication management. For infection, we give antibiotic for 5 to 7 days. For complication, we such as silosyl management, we do compressive dressing and botulinum toxin. For rehabilitation, we give speaking and swallowing therapy for regain the normal vital functions. And obviously the mobility of the jaw exercise mobility for wider opening of the mouth. These are the functional outcomes. Firstly, speech and swallowing. 69% of the patient regain the speech, and more than 80% patients can do understandable speech. It is best for mouth and tongue restoration. Some of the patients remain partially on feeding tube due to some complications. Then we the oral functions. 34% of the patient can fully eat by mouth. Then dental implant improves the chewing and swallowing after the surgery. As we first said that it also improves the quality of life of the patient, and it also gives the high cosmetic and aesthetic outcomes. These are some complications occurs after the surgery. Firstly, thrombosis, flap necrosis, osteoradionecrosis, hematoma formation, and salivary fistula formation. We can manage this complication through revision surgery or flap replacement. Firstly, for thrombosis, we do surgical exploration, and or we can do another microvascular anastomosis. For flap necrosis, we usually do debridement and reinsert the flap. For osteoradionecrosis, we preferably do hyperbaric oxygen therapy. For hematoma formation, we do hemostasis particularly, and for fistula formation, we do pressure dressing. These are the surgical results of a patient. Firstly, as I firstly talked that the success rate is over 90%. The total flap loss is less than it is nearly about 10 to 17%. Partial flap necrosis is shortly 6 to 8%. The functional result, maximum functional result can occur early, that is 75%. Some functional result can appear after some time. The rate is 50%. These are some advantages and disadvantages. firstly, it is a versatile repair. It can do versatile repair. The natural look, it regain the natural look and function. It works after radiation also, after CT scan and MRI. It has some disadvantages, like it is a complex surgery, donor area problems, and not perfect for all cases. Conclusion: the success rate is over 90%, and more patient can regain the oral functions. Thank you.
Sir, question from the judges. Yes.
Sanskar.
Yes, sir.
Regarding this study, since it's a systematic review.
Yes, sir.
Did you help in carrying out the review?
Sorry, sir?
Did you help in carrying out this systematic review in which you have presented? Or is it just you are presenting a review which you have read?
No, sir. I referred 5 to 6 articles for this.
What sir is asking is, what was your role in this study?
Sir, I only do reviews of some of the articles.
So you just reviewed some articles,
Yes,
right?
sir. Yes, sir.
So systematic review is a scientific process.
Yes, sir.
Okay?
Yes, sir.
So you should not be mentioning it as systematic review.
Yes.
Okay? So you reviewed some articles.
Yes.
You are a dental college student?
Yes, sir. I am a third year BDS student.
Third year BDS.
Yes, sir.
Okay.
What was your aim?
Sorry, sir.
What was your aim?
Sir, my aim is to deliver that the microvascular free flap is the most excellent surgery which can restore the normal oral function and vital functions, sir, after the surgery, sir, to regain the normal quality of life of the patient.
What were your objectives?
I don't know exactly, sir.
How did you try to prove your aim? That is, you wanted to prove that microvascular free flap is the best flap for achieving best functional outcome from these complex injuries of the maxillofacial region.
Yes, sir.
Okay?
Yes.
So to achieve that aim, you would have look for certain aspects.
Yes, sir.
So what did you look for?
Sir, firstly, our preference was the patient can regain its oral functions, that's such as feeding, breathing, and chewing. Because after the injury, some of the patient may last 2 to 3 years on the feeding tube, sir. And because of that, the patient cannot get the sufficient nutrition.
Okay, we'll skip the thing. What was the artery which is based on this anterolateral thigh flap is harvested?
Sorry, sir?
What is the artery which is harvested along with the anterolateral thigh flap to anastomose it?
Sorry, sir.
You used various flaps. You showed one photograph
Yes, sir.
that you used peroneal vessel based flap,
Yes, yes.
anterolateral thigh flap.
Yes, sir.
Come to that photograph. What is that flap based on? Which artery? You're not aware?
No, sir, I am not aware of that.
Okay. In the maxillofacial region, this free flap was attached with which artery?
On the maxillofacial area, sir?
Yes.
Sir,
You did the anastomosis with which artery?
Okay, sir. Sir,
You're not aware.
no, I am not that fully aware of that, sir.
Okay, thank you.
Thank you so much.
To say that microvascular is the best,
yes, sir,
you have to compare it with something else, right?
Yes, sir. We can compare it to the normal skin grafting, sir.
See, skin graft will not fill a defect.
Okay.
Skin graft will cover a raw area.
Yes.
So the articles that you referred to, have they compared it with some other technique and then they've reached its conclusion that microvascular is better? And second is, what are the contraindications in microvascular?
Yes.
where can it not be done? So have they compared it with some other technique?
Sir, I only compared it with the normal skin grafting technique, sir.
No, you referred to some 4 or 5 articles. So have those articles compared different techniques and reached this conclusion?
No, sir. Only one of the article that I give reference only compare with the skin grafting with no other technique, sir.
Okay, thank you.
Okay, thank you.
Okay, I just have one last question to
Yes,
you. Since you said it's a review article.
Yes, ma'am.
What are the guidelines available for reviewing an article, for systematic reviews? Did you follow any guidelines available?
Not actually, ma'am. But I stick to the clinical aspect probably because clinically the patient should regain its normal oral function. I only considered that.
So maybe you can take your study forward by going through the PRISMA guidelines.
Okay, ma'am.
So the PRISMA guidelines are for systematic reviews, which you need to be following before going ahead with the collection of information.
Okay, ma'am. Sure, ma'am. Thank you so much, ma'am.
Sanskar, thank you very much. So now we'll be having a presenter from number 7, Celine Raphael. She has to go somewhere, so she'll be presenting early. To medical cadet Celine Raphael.
Ladies and gentlemen, do you think a patient of multiple myeloma in India, Bangladesh, Bhutan, or for that matter, any South Asian country has access to key diagnostic investigations, key imaging modalities, the drugs used for treatment, or autologous stem cell transplant facility available at their doorstep? Well, my study aims to answer more such pertinent questions about multiple myeloma care in South Asia. 138,000 new cases of multiple myeloma occurred in the world in 2016, which was a 126% rise in incidence since 1990. There are a lot of novel therapies available in the world. However, the integration of these therapies has seen a wide disparity in the South Asian region. This is due to the varying economic status and healthcare infrastructure, inconsistent healthcare policies, and an acute shortage of trained specialists. The objective of my study remains to explore the availability, accessibility, and cost of multiple myeloma treatment across 8 South Asian countries. We created a structured web-based questionnaire using the SurveyMonkey software and emailed the same to physicians treating multiple myeloma in 8 South Asian countries. The structured questionnaire collected data from key areas, and our results were as follows. With the exception of Bhutan, all countries had both public and private institutions. The out-of-pocket expenditure sustained by patients in this region was a staggering 70.75%, with countries such as Pakistan and Bangladesh reporting it to be as high as 90 to 95%. At the time of diagnosis, 62.5% of the patients in the region presented with anemia. This was followed by bone lesions in Myanmar and hypercalcemia in Bhutan. The OPD of initial presentation was the medicine OPD, followed by the oncology OPD, and then the nephrology OPD. Key diagnostic investigations such as serum protein electrophoresis, immunofixation assay, and serum-free light chain were unavailable through public institutions in 62.5% of the countries. Although, fortunately, urine protein electrophoresis, fish cytogenetics, and MRD estimation by flow cytometry were available through public institutions in India. Key drugs remained available through public institutions in India. However, drugs such as IV melphalan were unavailable again in 62.5% of the countries. Key drugs such as lenalidomide and bortezomib were again unavailable through public institutions in countries such as Bangladesh and Myanmar. And daratumumab was only available through public institutions in India. Ixazomib, eltuzumab, and teclistamab were not available in the region and had to be imported where necessary. The treatment of choice for transplant-eligible patients in public institutions in the region remained VRD in 50% of the countries, followed by VCD, while in private institutions, it was VRD with daratumumab in 37% of the countries, and VRD alone. Coming to autologous stem cell transplant, with the exception of Maldives and Bhutan, all other countries had a public stem cell transplant available there. However, cryopreservation availability was only there in 25% of the countries, and availability of mobilizing agents like plerixafor were only available in 62.5% of the countries. Thank you.
Okay, and judges can ask the questions. That was quite a crisp and a good presentation. Okay. Yes, ma'am.
A wonderful presentation, Selina.
Thank you, ma'am.
I have a basic question. How comparable are these countries with respect to the health services available, the health systems available in each of these countries? How comparable are they?
Ma'am, there exists a wide disparity, ma'am, in terms of the policies that are present there in every country, in terms of insurance coverage or government subsidy available in all of these countries, ma'am. So there is a lot of heterogeneity, ma'am.
Okay. So, what is after doing the 8, sub-countries analysis, what is your take-home message for all of us?
Ma'am, I found that the socioeconomic status of a patient has the ability to affect their treatment outcome. And so policies need to be structured to enhance health equity, ma'am. In regions where drugs are not available, freely accessible through public institutions, imaging modalities, etc.
Salim, how did you select the doctors whom you sent the questionnaire to?
Yes,
That's my
sir.
first question.
Yes,
And second question is, you left the conclusion only on the slide. Why did you not discuss the conclusion? Because that's the most important part of your study, isn't it?
Yes, sir.
Just answer these two. How did you select the doctors firstly?
Yes, sir. So the doctors were all hematologists, hemato-oncologists. They were selected after a thorough review of literature, sir. And we made sure that there was at least one physician from the public institution from every country and one physician from a private institution in every country. And then they were selected. So 69% of our physicians saw more than 12 myeloma patients every month, and 38% of our physicians treated more than 24 myeloma patients every month, sir. So it was after a thorough review of literature that they were emailed, sir.
So how much was the response rate of these doctors? Everyone answered all the questions?
No, ma'am. So finally, out of all the 26 physicians, ma'am, we received 16 responses, ma'am.
And the physicians only gave you the out-of-pocket expenditure for the patients?
Yes, ma'am. Yes, ma'am. They estimated how much it would be in different countries, ma'am.
Because because of the availability and accessibility issues.
Yes, sir.
How do they talk about the outcomes?
Sir, so in most countries, sir, like Bhutan and Myanmar, most of the key drugs were not available. And so most of the patients were transported to India, sir. Maldives, the government in Maldives completely sponsors their travel to India, their treatment in India as well, sir. So they were mostly treated in India. So then, because they were transported to India, their outcomes were pretty fine, sir.
Okay. Yeah, Celine, I think you rushed through the presentation. You must be in a big hurry. That's why she skipped the conclusion slide, I think. Is there any urban-rural difference? Was that studied? A difference between urban settings and rural settings, or was it included? Just yes, no.
Sir, there was definitely a difference between the public and private facilities, sir, that were available. Like daratumumab being considerably higher, costlier drug, which targets the CD38 antigen present on the myeloma cells, sir. That specific immunological drug costs much more than other drugs, sir. So daratumumab was then only available in private institutions, and private institutions invariably mostly remain confined to the urban setup, sir.
Okay.
And it leads to a better result, sir.
Okay, thank you. So our next presenter is Sharayu Sunil Indukar.
Everyone, myself Sharayu Sunil Indurkar, a third-year student, and today I'll be presenting my research, which is exploring the role of sodium in causation of atopic dermatitis. Before beginning with the presentation, I would like to clarify that there are no acronyms, no conflicts of interest, and no ethical conflicts. Atopic dermatitis is an increasingly common dermatological condition which affects 2 to 20% of the individuals globally. Numerous studies have indicated that skin is involved in the regulation of total body sodium, and skin sodium may result in immunological dysregulations. Now the question arises, what is the need for the study? Atopic dermatitis has a complex and multifaceted pathogenesis, with several trigger events influencing the disease's incidence. It is impractical to try and manage majority of these events because they are unchangeable. A new field of study might be launched to investigate the molecular nature of atopic dermatitis if this correlation is proven, and given that it is a preventable factor affecting the disease's pathogenic prognosis. Research question: is there any correlation between the fluctuations of the dietary sodium levels and the prognosis and severity of AD? It is hypothesized that there is a positive association. The study was aimed to determine the correlation between the ranging sodium levels and severity and occurrence of AD. It is a case-control study which was carried out over a period of 6 months in the dermatology department of a tertiary care hospital. We included the patients willingly participating in the study after understanding the objectives and the procedure. We excluded the patients on any special diets, those with systemic illnesses such as hypertension, and those on antihypertensive medications. We made the diagnosis with the help of Hannifin and Rajka criteria, which consist of major and minor criteria. We graded the severity with the help of SCORAD criteria. We also used the Intersalt equation to determine the 24-hour urine sodium excretion with the help of spot urine sodium and spot urine creatinine values. Considering the prevalence of 3.1%, the sample size was calculated as 46, which we rounded it off to 50 to eliminate any possible dropouts. The study procedure. After the IEC approval, we formed 2 groups, a case group and a control group, containing 50 participants each, after which the informed consent was taken. We clinically and physically examined the patients and confirmed the diagnosis using the Hannifin and Rajka criteria and graded the severity using the SCORAD criteria, after which spot urine analysis of both the case and the control group was performed to determine the 24-hour urine sodium excretion using the spot urine sodium and creatinine values, after which the data was analyzed. This is the molecular basis of the research. In the diagram of the keratinocyte, you can appreciate the epithelial sodium channels. These are the concentration-dependent channels. When there is higher dietary sodium intake, the extracellular sodium will rise, which will open these channels, and there will be sodium influx. This will trigger the serine protease enzyme, which will in turn result in the upregulation of formation and release of the pro-inflammatory markers like IL-8 and IL-13. Coming to the result, we found a male predominance. The mean values of the BMI in the case group were again slightly higher than that of the control group. Here you can appreciate the typical flexural manifestation of atopic dermatitis. This is the typical hyperlinearity feature. Here there's the truncal involvement, which indicates the higher severity score. This is the facial involvement in case of pediatric group. Coming to the spot urine sodium, the mean spot urine sodium for the cases was calculated to be 157 millimole per liter, which was higher than that of the control. Similarly, the mean spot urine creatinine for the case group were again calculated higher than that of the control. The mean 24-hour urine sodium excretion for the case group was calculated as 3.93 grams per day, which was again higher than that of the control. Here, I would also like to mention that WHO has recommended 5 grams of salt per day, which equates to 2.3 grams of sodium. Here, the values are exceeding the normal ranges. Here, you can appreciate for 1 gram rise in the 24-hour urine sodium excretion, there is increase in severity, suggesting a direct proportional relation between the two. Our study findings are in accordance with the previous studies conducted. Chang et al. In 2028 in a study stated that 1 gram rise in the 24-hour urine sodium excretion was associated with 11% higher odds of AD. Mayfield et al. In 2022 in a study concluded that the lesional skin sodium in atopic patients were 30 times greater than that of the control groups. The relation between atopic dermatitis and sodium is novel in itself. Apart from hypertension, other pathologies, especially the cutaneous pathologies related to sodium, are yet to be researched thoroughly. If this hypothesis is proven, and dietary sodium is proven to be a culprit in worsening the prognosis and the causation of AD, a whole new arena of medical research would unfold. The conceptual basis on which this research is based is rather new, and according to the literature, the study design is also first of its kind and has not been conducted yet globally. In conclusion, considering the high salt intake in average person belonging to Indian subcontinent, if this correlation between the fluctuations in the dietary sodium level and occurrence of AD is proven, it shall be beneficial in regulating the pathogenic prognosis of the disease. Also, our study findings suggest that restriction of the dietary sodium may be a cost-effective and a low-risk intervention for AD. These are our references. Regards.
Thank you, Saryu, for a nice presentation and a good novel topic. And questions from judges, ma'am.
Yeah, very systematically presented,
Thank you,
study. But I have again very basic technical questions. So the first thing is, you say atopic dermatitis. How rare is it?
Ma'am, the prevalence in Indian setting is 3.1% according to the Karikar et al.
Okay, 3.1. So it fits into the case control study.
Yeah.
Perfect. The second thing is, you have been using the word correlation and association, interchangeably. Is there any difference between the two, or is it one and the same thing?
Ma'am, as per my knowledge, you can use it.
So
I
when
hope you
use
understood the question.
Yeah, correlation and association, the difference between the two.
It's self-explanatory. Think over it.
Yeah, ma'am, they are the same.
They're the same.
Correlation is basically, sorry, ma'am.
Okay. So I think you can just go back and read about it. Correlation is when
definitely,
you are
ma'am.
speaking for two quantitative. Association is when it is qualitative. And the third thing, what I found in your slide was, you have given the sample size for prevalence, right? You have calculated the sample size for prevalence. However, your research question and the hypothesis is regarding association, right?
Yeah.
So that sample size cannot fit for the association. It is for prevalence, which is not your research question.
Okay, ma'am.
Thank you.
What was the average sodium intake in the study?
In our study, sir, we calculate the intake according to the intersalt equation. So the average intake was, in the case group, it was higher. It was 3.93 grams per day. And for the control group, it was around 2.7.
3.93 itself is quite low. It's very surprising. Indians are supposed to take much more salt, maybe more than 10 grams
Because,
or 5
sir,
grams.
a lot of the patients in this disease were from a younger age group, from
Okay.
2 to 10. So
Okay.
their salt intake
Okay,
is higher.
okay. Thank you. Thank you.
Thank you.
Next presentation is Bilha and Jiki.
So very warm good morning to everyone present here. So I am Bilha from Kerala. I would like to start my presentation with this image. So what do you observe in this image? You can see medical students, but if you notice, you can see half of the population is having spectacles. This is an image you can see in every lecture halls across India, and even here, including me. So this is a simple study which is addressing a growing health concern. Coming to the title of my study, the analysis of potential risk factors for the development of refractive errors in medical students of Gen Z, a case control study. So the contents of my presentation are background, objectives, methodology, results, discussion, conclusion, limitations, recommendations, and reference. So you all know what refractive error is when the optical system fails to focus the parallel rays of light on the retina when the accommodation is being at rest. So coming to the statistics, almost 2 billion people are affected globally and 39.3 million are affected in India. So coming to the etiology of refractive errors, the etiology of refractive errors are further discussed under two categories, that is genetic and environmental. But the degree of contribution of both are under debate. So why in medical students? Because it has a high prevalence rate and the impact in medical students is more. Considering the near work and the decreased outdoor activities. And also our unique risk profile as we all are digital natives. And the refractive errors affect the competence, productivity, and quality of life. Now coming to the relevance of my study, it helps in public health significance, and also it has an impact on the student life by prevention. By analyzing the risk factors, you can prevent and improve the quality of life. And also the analyzing of risk factors will help in policy making and prevention strategies. And also in Kerala, there is a regional data gap because there are very limited studies done in Kerala, especially after COVID. Coming to the objectives of my study, it is to compare the contribution of genetic and environmental factors for the development of refractive errors, and also the rate of progression and quality of life, and to analyze the common type of refractive error and the type of corrective measures used and their compliance. Coming to the methodology, the study design is an observative study, case control study done over a period of 2 months in MBBS students of 4 years, and the sample size is 202, 101 in each category. This is the sampling method based on proportions of an earlier publications done by Kumar et al. The sample size come to 202. Coming to the methodology, after obtaining institutional research ethical committee approval and after explaining the procedure to the participants and after obtaining the consent, the study population meeting the criteria was divided into cases and controls. Cases have the refractive errors and controls without refractive errors. The data was collected by using a questionnaire, and the data included socio-demographics, family history, environmental risk factors, progression, and quality of life. And the data analysis was done by SPSS version 25 software and chi-square test. Coming to the results was divided into 5 categories: socio-demographic, genetic factors, environmental factors, characteristics of refractive error, and quality of life. So the socio-demographics, the mean age was 23.3, the sex distribution was females were more, and distribution was the myopics were more, almost accounting for 76% of the population, followed by astigmatics and hyperopics. Then coming to the role of genetic factors, this is the elaborate table, and the key findings are positive family history that accounts for almost 71% of the cases, whereas it was only 38 in controls. And it was more common in students with one parent, and in that itself it was higher in fathers. So next is the role of environmental risk factors. These are the conclusions, that is the exposure to sunlight, primary hobby, and reading distance were identified as potent risk factors. In exposure to sunlight, it was less than 30 minutes in cases and 1 to 3 hours in controls. And reading was the major hobby in cases, and outdoor sports and games was the major hobby in controls. And majority read equal to or less than 25 in cases, and majority read equal to or more than 25 centimeters in controls. Coming to the characteristics of refractive error, the age of onset was almost 11 to 13 years in all the 3 categories, and spectacles was the most corrective measure used, and the compliance was almost 70 to 80%, and the progression was more in hyperopics and compared to myopics and astigmatics. Coming to the quality of life, it was more better in controls when compared to cases. The mental health status was better in controls, and also the symptoms was more in cases. Coming to the discussion, in this study, myopia is the most prevalent study, followed by astigmatism. This is in tune with the studies such as in West Bengal, Odisha, Nepal, and Singapore. Whereas in other studies, hyperopia were more than astigmatism. However, in all studies, myopia was the most prevalent one. In this study, positive family history accounted for 71% in cases. This was also in tune with our mother study, that is Kumar et al. In Haryana, and also the other congruent studies. It shows that myopia is a polygenic trait which influences the visual system. And the potential environmental risk factors were all of these. This is in tune with the studies done in Nepal. And rate of progression was more in hyperopics than astigmatism and myopia. And the quality of life was better in controls than in cases. Coming to the conclusion, the myopic epidemic is a significant public health concern, and the contribution of both genetic and environmental risk factors have been analyzed in our study, and we recommend lifestyle modifications and early screening and correction for the prevention, and also increased awareness and education among medical students in ocular care, and particularly in school-going children, because the onset, age of onset is almost 11 to 18. Coming to the limitations of the study, less genetic analysis is done and recall bias may happen. It is also a single-centered based study and of short duration. Coming to the recommendations, screening and awareness is required, policy interventions are required at governmental levels, and good compliance to corrective measures will improve the, lessen the progression of refractive errors, and further research are needed for the genetic and environmental, the deepened contributions of genetic. These are the references, and thank you.
Okay, thank you. This is a very important problem which you are studying, which is seen in lots of medical students. So any question, ma'am?
Okay, very good, clear presentation, I would say.
Thank you, ma'am.
Since you have taken a case control approach, how far back have you gone for collection of the exposure status? Normally in case control, we take retrospective exposure, right?
Yeah.
So how back in time have you gone for collection of the exposure values?
We have analyzed from birth onwards. The refractive errors from birth till date.
And the exposure to environmental factors?
That also have been taken on a, from their joining medical college till the present year of their study.
Okay. And what was the scale used for mental health status?
The 5 point, I don't remember the name exactly. It is significantly impairment, persistent and significant mental retardation.
Two things which were found by you. One was environmental factors, and second was, these were medical students, of course, right? Yeah. At one point, you did mention that there's a certain lack of exercise, okay, physical activity. So how do you explain the two? What is your view on that? That people who have got an environmental exposure are likely to have refractory errors vis-a-vis a medical student who would have had a pre-medical few years of good studies and less of physical activity outside. These are two contradictory things. So how do you explain that?
So in some studies, they mentioned that children exposed to in their adolescent time, when they're exposed to sunlight, they're less prone to development of refractive error when it comes to their adulthood. But in our study, most of the population developed refractive errors around the age of 11 to 18. So it is almost of a NEET and those ways. So I don't think they have much of an outdoor activity. And even if they had outdoor activity, when comparing to after the majority of our population was almost in second year and third year. So they almost had 3 years of lack of inactive life. So they had the progression more in those time.
I have a question for you. When I was a kid at 10 years of age only, this television came up. Now, did you in your research work speak to all these candidates? At what age they started seeing television or using these electronic gadgets like tabs, laptops, and how many of them went to schools where these things were encouraged compared to those schools where these electronic devices were kept out of this thing? Did you factor in this?
We had analyzed
because most of these students are medical students. You studied only the medical students. Okay? So I presume that all of these students were studious in their young age itself to get medicine. Huh? How much of electronic devices did they use and from what age did they use? And do you think that it has a correlation? Because that's what is actually happening nowadays. Even the small kids are given mobiles to play with. No? Tom and Jerry is put on the mobile and the child is given that mobile so that the mother can cook food for the other kids and the husband before he come home. Huh? So tell me, did you factor in this?
No, sir, exactly. We had factored screen time, but not exactly the age of when they started using screens. But the screen time, when it comes to comparison with cases and controls, I think after the post-COVID era, the learning has come into play, and almost everybody has usage of same hours, even in labs or mobiles or whatever electronic devices they use. There was no significant correlation. Actually, in the hypothesis, I thought it would have had a significant contribution because the other studies showed screen time also as a risk factor. But in my study, I could not find out because I think after the post-COVID era, everyone uses it equally.
Taken till third year, no? Till
Yes.
20 years of age, I think 2021. So anybody underwent a LASIK surgery for any? Did they had any?
We had kept LASIK as an option in the questionnaire,
Okay.
but nobody had.
Nobody had done it. Okay, thank you.
Is this an ailment limited only to human beings? This, anything in animal kingdom, such a refractive issue coming up in animals?
I'm not aware of that,
Yes,
sir.
look into it. Huh?
Thank you. If I may, I would take 1 minute apart from the presentations. Myself, Bilha, I was, AFMC was a dream I saw 10 years back. It was this stage, this dais, standing here is a dream come true for me. Whether it's presentation or whatever, I never expected to come here and stand. It was due to my epilepsy, I couldn't get AFMC. I have that regrets. In this past 2 days, I am grateful to Illuminati for providing me with this experience of what I wanted in my life. And this is a moment I will cherish for rest of my life. Thank you.
Yeah, okay, thank you. Thank you. Okay, the next presenter is Swastika Mandal.
Good morning, respected judges and everyone present here. I have a question to ask everyone, especially the medical students and the doctors present here. What do you do when you, as a doctor, confident in your medical education, suddenly find yourself underprepared when a transgender person walks into your clinic? That is the exact situation our physicians found themselves in when Suresh, a transgender person, walked into our clinic. In India, nearly 27% of transgender individuals have reported that they have been denied access to healthcare. A total prevalence of HIV among transgender individuals is 48.8%, which is significantly higher than the 5.4% prevalence occurred in general population attending the same clinic. So we can conclude that we aren't just lacking the knowledge, we are lacking to provide the respect and the trust every patient deserves. We talk about equality in healthcare, but are tomorrow's doctors actually equipped to treat the transgender patients with the respect and the sensitivity they deserve? Let's dive into my topic of research, which is a knowledge, attitude, and practice study among second-year medical students regarding transgender health issues in a private medical college in Kolkata. My name is Swastika Mandal, and I am a second-year MBBS student. Now, who is a transgender person? He or she is someone whose gender identity does not align with the gender assigned to them at birth, irrespective of medical or surgical transition. These individuals often face unique healthcare needs that are often unmet due to systemic barriers and social stigma. The Transgender Persons Protection of Rights Act has been in the picture since 2019, but has it created any change in the level and attitude of and perception of medical students when it comes to TG healthcare? Let's dive deeper. The purpose of our study was to assess the knowledge of TG health issues, while our objective was to understand the attitude and practice of TG healthcare among second prof MBBS students. Our inclusion criteria were all the second-year MBBS students who had voluntarily given their consent, while our exclusion criteria was the students who were not willing to participate in the study, all the MBBS students of current first, third, fourth year, and interns, and all the paramedical students. We conducted a cross-sectional study for a period of 1 month, that is from January to February of 2025, where we asked 99 second-year MBBS students to fill out a validated Likert scale questionnaire consisting of 6 questions. The questionnaire had 3 themes, which is knowledge, education, and profession. After obtaining ethical committee approval and informed consent from all the students, we started our study. Our sample size was 99. After taking 95% level of confidence and D as 10%, and by using the Cochrane's formula, our statistician provided us with a sample size of 99. Then, by random number sampling method, we chose 99 students, and Mann-Whitney U-test was conducted using Stata 14 software. This is the format of the informed consent form that was distributed. Now, these are the 6 questions that I have been talking about. The first 2 questions encompass the knowledge theme, the middle 2 about the education theme, and the last 2 about the profession theme. Coming to the results, our results proved to be quite shocking, where we can see that majority percent of the students are not comfortable in treating transgender patients for gender-specific issues. And we can see that when it comes to their familiarity and comfortability in treating them, a small percentage of students have proven to strongly agree. If we plot the mean and the standard deviation values together, gender-specific variables have shown the highest standard deviation and the lowest mean, indicating significant inconsistency. But when it comes to understanding TG identity, we have recorded the highest mean and the lowest standard deviation. This is the response intensity heat map of the male and the female participants, where percentage distribution of each parameter corresponding to gender was taken. Over here, we have recorded the highest percentage, that is 76.2, amongst the female students about their strong support of including TG health issues in the curriculum, followed by 73.8%, where majority of the students wanted that they had got a better understanding of TG identity. Amongst males, the highest percentage recorded is 66.7, where when it comes to their basic understanding. This is the difference in opinion between male and female responses, where we can see that females are strongly supportive of including TG health issues into the current existing medical curriculum. In contrast to a study which was published in Pondicherry in 2022, our study has shown that nearly 63% of the students are aware of TG medical health issues, whereas in all other parameters, our study has produced nearly similar results in comparison to its national and international counterparts. I would like to say that in our study, females were proven to show more support, which was rarely analyzed in the national papers. Every study has got their own set of strengths and limitations, whereas our biggest strength was that it is one of the first studies to be done in the state of West Bengal, which correlates TG health with medical students, and the fact that we used a peer-reviewed, pre-validated questionnaire makes our study even more robust. At the same time, we're limited by a small sample size, no comparison group, and a potential of self-reporting bias. As I come towards the end of my presentation, I would like to say that a study has highlighted the lack of TG-inclusive training among second-year medical students, where majority have expressed the need for more education on TG health. Early academic exposure can improve future doctors' quality of care and professional behavior. At the same time, we strongly recommend immediate incorporation of TG health into the medical curriculum. These are the sets of references which I've used. And as the saying goes, a journey of 1,000 miles begins with a single step. In a similar way, our study has been a humble effort to make healthcare inclusive for everyone. I would like to acknowledge my friends, my family, the principal of my college for their constant guidance and support. Thank you so much for your patience.
Thank you, Swastika, for such a new, innovative, and novel topic to be researched.
Thank you, sir.
Any questions from judges?
Hello. Yeah, Swastika, very good study.
Thank you so much, sir.
Now, you have included only till the second year of it.
Yes, sir.
MBBS, right? Do you think, since you excluded the senior medical college students, do you think your results would have been slightly different regarding the approach?
Yes, I think it would have been different if we included especially the interns and the final year MBBS students, because they have more knowledge regarding the human body.
Okay. Thank you. The second question is, you mentioned about TG health.
Yes, sir.
Right? You've been frequently mentioning it. Now, what specifically do you think should be included in the curriculum regarding TG health? Which you say that it's not there.
Yes,
so
sir.
What specifically do you think should be included in that curriculum?
So firstly, I think that majority of the students don't know how to address a TG patient. Like, would that patient like to be addressed as a he or a she? So we should start with basic communication workshops, case-based workshops, and sensitization camps with like Department of Endocrinology and Psychiatry, so that we can incorporate all of these issues into the curriculum. And also spread more awareness.
So it is more related to the awareness component rather than specifics related to their health disorders.
So we can incorporate that into the health disorders, but I think that since my, I worked with second-year MBBS students, at this point, incorporating communication skills and everything else would be more conducive to them rather than talking about all the surgical aspects of this, which we can take it further. There are no regulations regarding TG health in India. So if we can take baby steps and then proceed towards more complicated and the surgical aspects, then I think that would be the best option.
You would be having ATCOM modules in your college?
Yes, sir, we have.
Okay. Thank you.
You're welcome, sir.
Okay, Swastika, I have two questions to you.
Yes, ma'am.
First is social identity, and you also have the cultural barriers, which to some extent is also creeped up in your results part.
Okay, ma'am.
So how much do you trust your own responses, which have come from your own, peer groups?
Ma'am, thank you so much for your question. But I have full confidence in all the responses because none of the identities, all the participants, there was blinding. So I think that there would be no level of bias in all the answers. So I guess I have full confidence in all the responses.
Okay. And the second question is with respect to statistics. Again, I'll come back
Yes,
to
ma'am.
my own subject. Since you have taken mean and standard deviation for Likert scale going from 1 to 5, how do you justify that? It's a Likert scale on 1 to 5, the
Yes,
scoring
ma'am.
is being done. So how do you justify taking mean and standard deviation in such a case?
Ma'am, like the mean, when we, like if you go through the tables, then we have seen that the mean is nearly like 5 in all of the responses. While the standard deviation, like as I have said, in gender specific concerns, the standard deviation is the highest.
No, but
So-
using mean and standard deviation is correct when it is a Likert scale, or would you have opted for median scores?
Ma'am, I have incorporated median scores as well, like when I was comparing the male and the female responses. So I have done that as well.
Thank you.
You're welcome.
I have one question here.
Yes,
You mentioned that the females were more empathetic and males were less. Any speculation on the reason thereof? Because that will need to be addressed.
No, sir. I think that females are much more empathetic, which we have also seen in our study, because they show stronger support, and it might be also be due to cultural and social hardships which females have to face, which has made them even more empathetic to include TG health issues.
So how will you propose making the male more empathetic? I mean, you'll have to do something to correct that, right?
Yes, sir. So for that, we can, like as I have said, we can hold more workshops and everything, so that like males have shown more aware. Over here, we can also see that males are not really that much aware as well. So first, we need to make them aware of the issues so that they can feel like about it. So that is, I think the first step should be making the males more aware, rather than making them like urging them to be more empathetic and be more supportive of such an inclusion.
Okay, thank you.
You're welcome, sir.
Thank you. So coming to the last presenter, Medical Cadet Rupika Pilla will come and present.
A very good morning to one and all. I am Medical Cadet Rupika Pila, here to present my study, Mapping the Regional Disparities and Research Trends in Multiple Myeloma Clinical Trials, a focus on South and Southeast Asia. Multiple myeloma is the third most common hematological malignancy following leukemia and non-Hodgkin's lymphoma, which has seen an increase in incidence by 126% from 1990 to 2016. There persist disparities in research priorities and geography. Our objectives was to classify ongoing and completed trials on multiple myeloma and identify the research gaps in existing research efforts in the South and Southeast Asian region in order to promote equitable myeloma care. The data was sourced from clinicaltrials.gov and CTRI using the mesh terminology myeloma. We collected the data of the last 15 years and then classified this based on the geographical location and the type of study based on the trial characteristics primarily into interventional and observational. This data was then presented as choroplets and hierarchical charts. This is the classification of interventional trials, firstly into therapeutic and non-therapeutic. Therapeutic ones involves those that are directly focused on therapy towards myeloma, based on the patient population into NDMM patients, RRMM patients, and trials involving both of them. Again, further into pharmacotherapy and cellular therapy. Pharmacotherapy again into allopathy and Ayush or CAM, complementary or alternative medicine. Allopathy into comparative and non-comparative, and based on the type of therapies used, whether it was a single drug therapy or a combination of therapies. The observational trials were classified based on whether they focused on prevalence, risk factors, diagnosis, or outcomes. These are our results. You can see how China clearly dominates the number of trials in the South and Southeast Asian region, followed by Japan and Korea, then India, Malaysia, Thailand, and Philippines, with many countries that do not have any registered trials so far. We see a very high number of trials on RRMM patients, clearly indicating the highly refractory nature of multiple myeloma. The following video contains the study divisions in trials of RRMM patients. You can see how there are a huge number of trials on pharmacotherapy and very little on cellular therapy, with certain countries such as India, Thailand, Philippines that do not have any trials in the last 15 years on cellular therapy. Moving on to the results of both NDMM and RRMM patients, where the studies are comparable of pharmacotherapy as well as cellular therapy. But there are still many countries like Malaysia and Thailand that do not have any registered trials on cellular therapies. The observational studies were primarily focused on the outcomes. In conclusion, while China, South Korea and Japan have led the multiple myeloma trials, various countries such as Sri Lanka, Nepal, Bangladesh, Myanmar, Pakistan, Bhutan, Afghanistan, Maldives, Cambodia, Indonesia and Vietnam do not have any registered trials on multiple myeloma in the last 15 years. There were more of interventional trials and mostly focused on the pharmacotherapy with limited accessibility to novel therapies. There are very fewer observational studies. There exist regional disparities in multiple myeloma research that needs equitable trials. Countries can aim for collaboration and novel treatments that can improve the multiple myeloma outcomes. We have come up with a framework for the various countries, with China that focuses on a lot of clinical trials and fewer on observational trials, thereby leading to lesser studies on the epidemiology of multiple myeloma and a lot of urban and rural variation. South Korea and Japan have a fewer trials on geriatric population. India has balanced trials and fewer studies on the Ayurveda, but it can focus more on the cellular therapies as well. There are a lot of countries, the underdeveloped countries, LMICs, that do not have any ongoing clinical trials. So we have come up with a list of organizations that they could seek funding from. This study would also provide a framework for international organizations like International Myeloma Societies and various NGOs across the world that aim at funding these clinical trials in the underdeveloped countries. This is also a framework for patients for their knowledge to know where they can go to if they want to seek a particular treatment. Thank you.
Rupika, for this crisp presentation. Any questions from judges?
Okay, Rupika, again, very good presentation.
Thank you, ma'am.
I think it's going in line with what Selina also presented. So I just want to know why the focus on South Asian countries and within the South Asian countries also. For example, if you take China and Thailand, what is the difference in the prevalence in these two countries?
Ma'am, firstly to answer your first question, why the South Asian countries? In the last, from 2008 to 2017, the clinical trials in these areas has become sevenfold, because this area has a lot of ethnic variations, a lot of genetic variations, and also the population here is naive to the treatments that is mostly present in the West. So the number of clinical trials have increased sevenfold. Despite that, there is a lot of variations that is reflected in this study. Secondly, the trials in China are funded by companies, pharmacological companies. So the number of trials here is more, even though prevalence remains more or less same across all South and Southeast Asian countries.
Okay, so if you look at China, this is now clinical trials that you are speaking. If you go in for systematic review, meta-analysis, again, they are the leaders in that.
Yes,
you have most of the systematic review meta-analysis coming out from China as such. So, since you're speaking about regional disparity, the regional disparity is also in terms of burden of the disease, the resources available with individual countries to go ahead and conduct these studies, right?
Yes, ma'am.
So, how do you think of taking this forward, in the sense that what are your recommendations apart from the framework that you have developed?
Yes, ma'am. Ma'am, when I was going through how to give about a framework for the countries, I came across a lot of trials, a lot of countries that are ready to take in patients from other LMICs, and those countries will also be counted in the trials. So these LMICs can collaborate within the nations, neighboring nations, as well as the international bodies.
No questions, thank you. She's answered most.
Okay, sir, so you can do the concluding remarks.
If there are no more questions, we come to the end of this session, and I congratulate all the participants for having put in great effort in making this event successful. I once again tell all the young students here to first think of how to reach a how to develop a research question, no? And then how to formulate an aim, then how to, what objectives you should have to achieve that aim, okay? So if you have simpler questions, probably you can find solutions more easily, okay? Anyway, with this we come to the end of this event. I thank all the judges for their active participation and making a decision on who is the winner. Okay, thank you. Thank you all.
And that's it up on the Incendium finals. A heartfelt thank you to our esteemed chairs and judges. Your time, insight, and razor-sharp questions lit up the session. And to our brilliant participants, bravo! You brought the heat, the heart, and the hustle.
Delegates are to note that the awards will be distributed during the valedictory ceremony at 2 p.m. in this very auditorium.
वो रहेगा ना यूट्यूब पे बाद में भी रहेगा सर, आपको बाद में शेयर कर देंगे। हाँ वही उसके बाद सर वेट फॉर
Check, check. Check, check.
Moving ahead, we now have the second guest oration of the conference. This time, we dive into history with a talk that promises valor, vision, and legacy. Our distinguished guest speaker will be taking us on an odyssey through the Maratha Empire, a saga of strategy, strength, and statesmanship.
The chairpersons for the oration are none other than a beloved Commandant, Lieutenant General Pankaj P. Rao and Air Commodore Anurakshat Gupta, HOD Surgery.
Both our chairpersons today have been absolute legends, insightful, inspiring, and truly the best in the game. Their presence is invaluable, and we couldn't have asked for a more stellar duo to guide the session. We now invite the chairpersons on the stage and humbly ask them to take over.
Hello. I think sorry for the delay, and I think without wasting any further time, it's actually my proud privilege and a real honor to be chairing a session by none other than our own college alumni from the M batch, Dr. Uday Kulkarni. Uday sir, after passing out, he surgery from Mumbai, worked as a surgeon, a great job he did there. Then after taking voluntary retirement, he worked in the KEM hospital here as general surgeon. But he always had a passion for history, for something more than surgery. He went on to do his PG in journalism and communications from Pune University. As he was passionate about history, especially the history of the Marathas, the 17th and the 18th century history, he passionately read about it, traveled the world over, spent hours and days and months and years researching on the Maratha history. And he's come out with 8 books to his credit, which are all thoroughly well-researched. Now he's an historian, he's an authority, and all his books are bestsellers in their field. He is now called all over the world to give lectures and orations. And during the Diamond Jubilee, we had the proud privilege of calling him to give a lecture to us. And I had been to his home, where I could see his passion. He's traveled wherever there were wars that were fought everywhere, and he's still got the artifacts, the sharpnels, the pieces of armory from the battlefield. Because that time I had just come back from, after commanding MH Wellington, and I was talking to him about the Battle of Assi. And he said, I have been to that place. Assi is a place near Jalna in Maharashtra. And he said, we have traveled there. We have seen where exactly the war was fought between the Marathas, I think the Scindias and the Bhosles, and the British troops by that time the Duke of Wellington, who later went on to defeat Napoleon in the Battle of Waterloo. And he's collected actually the pieces of shrapnel, the armory, or whatever he found over there. And that actually was very fascinating to see. And without, I think, wasting further time, I would request Sir to kindly deliver his oration. And again, once again, I'm sorry for the delay, sir.
Hello. Thank you, General Rao. It's a pleasure to always be back in AFMC, and the first time I was here was 51 years back, and it hasn't changed much, and it's a wonderful place to be back again and speak on a subject which is now a bit closer to my heart. I mean, after going through the whole gamut of going through medical college, spending 4.5 wonderful years here, and those 4.5 years, I think, are the basic roots which you grow and which your life grows on later on. So it may be 50 years, 60 years, 70 years from the day you joined this college, but this college stays with you. It remains inside every pore of your body, and what you become later on is because of those 4.5 years that you spend here. And in the last few years, I switched kind of my profession from being a general surgeon and a PG teacher and doing all that kind of thing to returning what I think, looking back, was my first interest. Because when I was in school at the age of 10, I wrote my first book on history. And then I revised it when I was 13 because I thought it was too childish. And then, of course, we get into the whole business of finding a career and getting admission to medical college and so on. And I was fortunate to get into AFMC. And of course, then you want to do your post-graduation and your whole career is ahead of you. But sometime in the early part of the century, 2005 or so, that itch came back, that I had to get back to what my childhood passion was. And that's how I began reading more. And actually, I found that a lot of accounts that you find are biased or they are not complete in themselves. And 2011 was the year when it was the 250th anniversary of the Third Battle of Panipat, one of the most ignored battles of the 18th century. And therefore, I thought I'll bring out a book which deals with this third battle, which was fought with the Marathas and Ahmad Shah Abdali of Afghanistan. And that first book I brought out, I told my wife I'm going to spend for it myself. And I took her approval also for spending 1.5 lakh rupees for that, which I said are gone. Fortunately for me, that didn't happen. Within a year, the books were sold and the second edition came out. And then people kept expecting me to write more books. And that's how another 7 books came out. So today, I'm on to my 9th book. So that is what actually happened. And that's how, in between so many years in the Navy, lots of memories to look back on. And therefore, from that, I have found that today I'm gracing the stage as a speaker of Indian history rather than a surgery. But before I go any further, I'd like to say the first thing that you have to do when you start writing history is you have to take a leaf out of your profession as a doctor. And like you preserve an arm's length with your patient and you're dispassionate when you're dealing with your patients. You don't get involved in their illnesses. Similarly, you have to keep history at arm's length and you have to be dispassionate when you're reading it and writing about it, because it is impossible to keep bias completely out of what you write, but you have to minimize it. And for that, a certain element of being dispassionate about it is very important, because I don't think that any unbiased history has ever been written by anybody. So from there, we come to the beginning of this talk. And it's a big subject to finish in, say, 50 or 60 minutes that we have today. So we'll have to hurry through it. But I realize that there will be many questions at the end of it, because you cannot go into details of every single thing that happened. But the purpose of this talk is to awaken an interest and to generate questions in your mind. And I hope that besides your medical curriculum, you'll have time to try to find answers for these questions. And if I manage to do that at the end of my talk, I think it'll have been worth it. So in 1526, you find the Mughals came to India, and the first battle of Panipat was fought in 1526. And already by that time, India was under the Delhi Sultanate for a good, at least 3 centuries, one can say. And the Delhi Sultanate had gone all the way down till Madurai in Tamil Nadu. It was not only a Delhi-centric kind of kingdom or an empire. And except probably a small period when the Vijayanagar kingdom was south of the Tungabhadra, it was largely a Turco-Persian Afghan rule that you find from the 13th century onwards till the 17th century. And it was not just the Turco-Persian Afghan rule, but we also had Persian as a state language till 1835, when the English changed it from Persian to English. And there was also, the state religion was from Arabia. The jurisprudence also largely came from that place. And the taxation was skewed towards the ruling class, or those who would embrace their faith. So, though they would never match the original Turco-Persian ancestry, they still had an advantage over the remaining people of this country. So this was the situation when Chhatrapati Shivaji was born in 1630. And his father had tried to rule the kingdom of Ahmednagar, which was under the Nizam Shahi, by proxy, because the young infant Nizam Shah was under threat by the Mughals from the north. And however, that did not succeed, and the Mughals captured Ahmednagar, and he had to go and take up an employment with the Adil Shahi of Bijapur. And that is when he was granted the Jagir of Bangalore, which remained with him for the next 50 years. His wife, Jizabai, and his younger son, Shivaji, came back to Pune in 1642. That time Shivaji was just about 12 years of age. And that time in 1630s, Pune was a devastated place. It was completely destroyed. There was a Bijapur general who had come here in the 1630s, completely destroyed the city. The inhabitants had been chased out of the city. There was a symbol in those days that you plow the ground of that place with a donkey, and you hammer a iron rod in that place so that people know that this place should never be inhabited again. So that was a state in 1642 when the young Shivaji with his mother actually comes back and looks after his father's Jagir, which is also the district of Pune today. So not only was it completely devastated, but it was infested by wolves. So one of the first things that were done was that there were awards given, 5 rupees per wolf which was killed in this region. So that is the state that Pune was in those days. And living on the other side of the Katraj Ghat, Khed Shivapur, the whole task of rebuilding this place, getting rid of the wolves, encouraging agriculture, bringing commerce into the city, letting people come in for inhabit here, building houses for them and so on. The whole process started. And by the age of 16, he was ready to gather his followers, because to go around, moving around all the valleys and hills of this region, collecting for followers who were kind of imbibed the same spirit of Swarajya, which he was aiming for. Swarajya translated into English obviously means own rule. And you'll find it very surprising, but Swarajya as a word has been used in our history only twice. Once when Chhatrapati Shivaji began his endeavor of getting freedom for his people, and the second time when Lokmanya Tilak used it against the British. So this entire thing of the next, and you find Pune remains the epicenter of this entire struggle against oppression, struggle against some kind of slavery which has been imposed by foreign rulers for the next 3 to 4 centuries, right up to 1920 when Lokmanya Tilak died. You find all the revolutionaries and all the freedom movements are all emanating from this city. So this was the picture when Shivaji actually began at 16 years of age. And this is the seal that he created for himself, which in Sanskrit said, Pratipachandra Lekheva Virdhishnu Vishwa Vandita Shaha Suno Shivasyaishya Mudra Bhadraya Rajate. Translated, it says, ever growing in splendor like the moon of the first day of the bright half of the moon and adored by the world, this seal of Shivaji, son of Shahaji, shines for the benediction of all. And the important part of the seal was not what is written in it, but also that it was written in Sanskrit. Because his own parents also had their own seals in Persian. So that marked a change, and that was a signal of what he believed in. And later in his life, you find he tells some of his ministers that you compose a new dictionary, which he called the Rajya Vyavahar Kosh. And in the Rajya Vyavahar Kosh was a systematic attempt to weed out several Persian and Turkish words which had crept into the Marathi language. And today we use so many of these even today, like suppose sabun. The word sabun is from Turkish origin. So these things had all crept into a very large way. If you see letters of that time written in Marathi, more than 50% of the words were written in Persian. The words were used from the Persian language. So this statement was what actually marked him out as different from what others were. And the very next year in 1647, he began to spread his wings. And at the cost of the Adil Shahi of Bijapur, he started taking the forts around Pune. There was fort of Purandar, the fort of Torna, the fort of Sivamagad. They were all captured. And the Bijapur Sultan first tried to pressure him by imprisoning his father. So at the first, he let his forts be returned to Bijapur. But later on, his father in Bijapur declared that I am not responsible for my son's actions in Pune, and I cannot control him anymore. And after that, you find from 1648 onwards, he continued his activities. But till 1656, when he was almost 26 years of age, you find his entire activities were restricted to the district of Pune. Now, what happened in 1656 which changed this? In 1656, the Sultan of Bijapur, Muhammad Shah, whose tomb is the Gol Gumbaz in Bijapur, he died. And there was a infighting in the Bijapur court. They became very weak. And on the other hand, Aurangzeb, who was the Subedar of the Deccan, had to go north in 1657 because his father was ill in Agra, and he had to go and fight the battle of succession with his other 3 brothers. So there was a vacuum in the Deccan which he took advantage of. And the next thing you know, he steps out of Pune city. He crosses the Western Ghats and he reaches the places of the inland waterways of Kalyan and Bhiwandi, which he captures. And with the help of a Portuguese father and son, surnamed Vaigas, he builds the first 20 Maratha ships and lays the foundation of a Maratha navy. Now look at the whole sequence of events. A man who is from a landlocked region goes to the sea, and the very first year he goes there, he's got this vision of going and establishing a navy because he's aware the future invasions which come into India are quite likely to be by the sea. And therefore in 1657 he begins this process of building ships. After 20 ships have been built, the Portuguese tell these two, father and son, that please don't help them anymore because they might be a problem for us later on. Those people stopped giving their help. But by that time, the Marathas had learned how to build their own ships. First example of transfer of foreign technology. And so this navy was established by 1557-59. And in 59, finally the Bijapur Sultanate got their act together. And one of their senior most generals at that time was Afzal Khan. They decided to send a huge army to either capture or kill Shivaji in Maharashtra. So Afzal Khan comes towards Shivaji's stronghold, and Shivaji is at that time near Mahabaleshwar in the fort of Pratapgarh. Now the Pratapgarh's position is very well chosen because it's surrounded by very thick jungles. Even today there is a thick jungle around the fort of Pratapgarh. And the entire endeavor of Afzal Khan is to draw him out into the open plains where he can get a hold of Shivaji Raja. Now, on the way to pull him out of that his stronghold in Pratapgarh, he first attacks the temple of Turja Bhavani at Turjapur. Then he attacks the temple of Pandharpur, thinking that these kind of actions will draw him out and he can come on the plain ground and fight with him. But he does not come out. He pretends as if he is scared of Afzal Khan. And when Afzal Khan comes to Vai, near Mahabaleshwar, he sends his wakil that I want to meet you. And he is forced to leave his army behind, go with a very small army to meet him at Pratapgarh, where in a single, he agrees, he says, I will meet you only 1-to-1, and each of us must not have more than 2 people with us. So a big tent is arranged below Pratapgarh where they both meet, and both have got, they are very clear in their mind that this is not a simple friendly meeting. It is designed either to capture or kill Shivaji and take him back to Bijapur, and therefore I have to defend myself. So he had gone with a skull cap which was made of steel. He had worn a armor inside his thing. He had a Vagnak in his one hand, and there was a stiletto up his sleeve. Similarly, Afzal Khan had a same kind of weapons. He had a knife in his wrist, hidden there. And when they met and Afzal Khan tried to embrace him, a tall, towering person compared to Shivaji, first thing he did is try to stab him in the back. And when he was stabbing him in the back, he took out his tiger claws or Vagnak and plunged them into his abdomen and kind of pulled his innards out. Then they had a short sword fight, before which the 2 people who were with them started rushing in. And in the melee, Afzal Khan was killed. And one of Shivaji's men came and cut off his head and took them to Pratapgarh. And the whole lot of army of Maratha was hidden in the jungles around that. They pounced on the Bijapur army and defeated them. And a string of forts right up to Kolhapur was captured after that. So this was a major event which sent a message to everybody that not only can he tackle a big army on his own, but he is personally brave enough to face a much bigger and stronger adversary in a 1-to-1 combat. In 1660, Aurangzeb's own maternal uncle came and occupied Pune. And he stayed in Shivaji's own house in the Lal Mahal, which has been rebuilt recently. And he stayed there for 3 long years. And one day in a marriage party, when Shaista Khan is surrounded by rings and rings of defensive forces, his forces, about 300 to 400 men, they mingle with the marriage party at night, enter the Lal Mahal by secret walkways and tunnels, and enter Shaista Khan's very bedroom. And there, Shaista Khan manages to escape by jumping out of the window, but not before losing 3 fingers of his right hand. And from there, you find the Subedar of the Deccan, who was sitting in Pune, withdraws. He comes in the bad books of Aurangzeb for having fallen prey to a sudden attack of this kind. And he is banished from there and sent as a Subedar of Bengal. 1664, to fund his various forts, building of forts, his navy, his seaports which he built, like the fort of Sindhudurg, Vijayadurg, Kolaba, they were all sea forts built by him. He attacks Surat, and he writes, the English letters at that time say that he tells Aurangzeb that you have forced a war on my people, but I will not pay for that war. The war will be paid by money which I take from you. And the money acquired from Surat is used to build his defenses, to build his forts, to build his seaports, and to augment his strength to fight back at the Mughals at that time. In 1665, a huge army led by Mirza Raja Jai Singh of Jaipur descends onto the Deccan. And after a valiant fight which went on for a few months, Shivaji comes and meets Mirza Raja and appeals to him that you are also a fellow Hindu like me, and it doesn't get you anywhere by fighting this kind of a battle. Let's come to an agreement. So Mirza Raja, of course, tells him that you must give up so many, 2/3 of your forts to me, and you must come to Agra and meet Aurangzeb. That is what leads to his expedition to Agra, where he is put under house arrest. And of course, the escape from the house arrest in 1666 to return to his capital at Rajgarh is a part of folklore, and most people will be aware of his escape from Agra at that stage. He comes back from Agra, and then for 4 years he holds the peace with the Mughals. And during those 4 years, he rebuilds his whatever defenses were weak. He rebuilds his administration. He decides on what steps he has to take so that the future attacks he is not vulnerable. However, it was in 1669 that you find that Aurangzeb passes 2 orders that all the temples of the Hindus have to be destroyed, principally the one at Mathura and the one at Kashi Vishweshwar. And no new temples are to be built, no repairs on temples are to be built. So when this happens, Shivaji again starts his offensive against the Mughals, beginning with the capture of Simhagad on 4th of February 1670 by Tanaji, which of course those who have seen the movie will be aware of in a very colorful manner. They have portrayed it. So that is where the war begins. And in 1674, he realizes that if he has to rise above the general zamindars of the Deccan, he has to crown himself as the king. And he crowns himself as the king on the fort of Raigad in 1674. A very graphic account is given by the English wakils of Bombay who were present at that time, how the ceremony went through. And one of his chroniclers is named Krishnaji Bhaskar Sabhasad. After his death is written, in such a manner was the Raja installed on the throne. In this era, on the entire earth, the Mlench Badshahs rule. The Mlench is a word which is used for anybody who is not Indian. It may be Greek, it may be Ionic, it may be Turkish, it may be Mughal. That the Maratha Padshah became the Chhatrapati was not an event of ordinary import. So this is the impact that his coronation had on most of the people living in Maharashtra, because he had not yet gone out of Maharashtra. After his coronation, he undertook the campaign to the south with some kind of premonition that I must have a depth, what in the army terms you got to have a strategic depth. Because if the Mughals come back again and they reach Maharashtra, I must have another place to go and take refuge. And he goes all the way down to the Kaveri. Even today, the biggest fort, the medieval fort in India is the fort of Jinji, which is in Tamil Nadu. So he goes and captures the fort of Jinji. He reinforces the fort, makes it so strong that it's not difficult for anybody to capture it. He takes the Qutub Shah's army from Hyderabad with him. The Qutub Shah agrees to extend the hand of friendship. And together, his army and Chhatrapati Shivaji at that time, they go down, capture the entire region up to the Kaveri. South of Kaveri, of course, is his cousin who's ruling from Tanjavur. And after that, when he comes back in 1680, after a very short illness, those days you didn't have to have a named illness, just a long fever or some kind of that was enough for a person to die. And 1680 he died. Now many of you have probably seen the recent movie which has come about this, and a lot of interest might have been generated about it. I have not seen the movie, but I'm sure it has been overtly dramatized. But yet there is an element of truth what is portrayed in the movie. Now, what did Chhatrapati Shivaji really achieve in his very short period of a life of 50 years, out of which probably 25 years was spent in establishing and expanding his... First thing is he gave considerable relief to the peasants who were taxed in it is a differential system of taxation. there have been notes and farmans given in the time of the Mughals that if the revenue, even if the famine and the revenue is not paid, the land revenue, sell the family of the farmer and recover the money if required, sell them as slaves. So there was relief to the peasants in the form that if the famine year, the taxes were reduced, new land had to be cultivated. Over the next 5 years, the taxes gradually increased. The Maratha Navy became a credible force which lasted for another 100 years after him. Many seaports were developed. And there was a kind of a cultural renaissance, if you see, because there are examples in Tamil Nadu or even in Goa where the Saptakoteshwar temple has been named, as those were the places where Aurangzeb's army had demolished temples and built mosques in their place. Pointed out to him, he demolished those and rebuilt those temples. A kind of a cultural renaissance began at that time, and he was very clear about his objectives. At the same time, as a seal said, his last line says, there is benediction for all. He did not discriminate between communities when they come to him for any particular justice which was sought by them. After this is the period you come in this movie which I mentioned some time back, and there was a change in the entire milieu of the Deccan at that time. So what was this change? There was a dispute at the top because the two children he had, one was the elder was Chhatrapati Sambhaji and the younger was Rajaram. And Chhatrapati Sambhaji's mother was no more. Rajaram's mother encouraged that he should be put on the throne. And there was a short period, there was a bit of a dispute until Sambhaji came back and controlled. But then there was distrust among the ministers who had gone against him at that time. And therefore he began trusting a Kanauji Brahmin named Kavi Kalash to become his confidant. But another development which took place was, at that time, Aurangzeb was fighting with the Rajputs of Jodhpur. And during that battle, one of Aurangzeb's sons, whose name was also Akbar, revolted against him. And not only did he revolt, but he had to come down to the Deccan to take shelter with the Marathas, and he took shelter with Chhatrapati Sambhaji. And therefore, Aurangzeb's direction changed, and he came down to the Deccan pursuing his son. For a long time, he also had it in his mind that he has to take over the kingdoms of Bijapur and Golconda, which in 1685 and 1687 he took over, defeating those two states. And after that, his entire attention was focused on the Marathas. And probably in a moment of not being very alert or whatever, you find that Sambhaji is captured in the Konkan at Sangameshwar. Sangameshwar was a relatively safe place to be in actually, because the entire western Ghats were full of thick forests. And the Mughals on the plateau, for them to come down through those jungles and attack Sangameshwar was it was a very far-fetched thing at that time. But he was surprised by one very energetic Mughal officer. His name was Mukarrab Khan. He came down very rapidly and he was unawares when this Mughal force came. He was captured along with Kavi Kalash. 40 days of torture followed, because he was taken about 250 kilometers, 300 kilometers away to Aurangzeb's camp, which was at Bahadurgarh near Pune. And Aurangzeb wanted him to not only disgorge the entire treasures. Shivaji Maharaj had left behind a huge amount of treasury was full. He had about 350 forts. He said, either you tell me the places where you kept your treasures, and you hand over letters handing over all your forts in the Deccan, which of course he scurrilously refused. And this was the main demand, because of which he was blinded, and for 40 days he was tortured. His tongue was cut off and limbs were cut off, and finally on the 11th of March 1689, not only was he killed, but the parts of his body were dispersed all over. And people were told they should not touch these parts and not give it a decent burial. Still on Nagar Road is a village called Vadu, where the villagers are still today called Shivle. Shivle in Marathi means they have touched something. So they've got the surname of Shivle because they picked up these body parts and cremated them. And therefore a samadhi of Chhatrapati Sambhaji exists today in that village. His head was cut off and taken somewhere. In fact, it was put on a spear and paraded all over the towns to show that the king is dead. And that head was finally buried in a place at Tulapur. So there is another samadhi of Chhatrapati Sambhaji at Tulapur. Now, any emperor who comes down from Delhi and has finally captured the king and killed him, and he would be justified in thinking that his job is done. And the Marathas, like the Bijapur and the Golconda sub-sultanates, have also been defeated. But here they were mistaken, because this death sparked a tremendous battle against the Mughals at that time. And from 1689 till Aurangzeb's death in 1707, he had no rest. In fact, though the entire Deccan was devastated at that time, there was a huge famine, hundreds and thousands of people were killed because of that, and a war continued everywhere. Rajaram was sitting in the fort of Jinji. He had escaped from Raigad and gone back there. Raigad had been captured. Sambhaji's wife and son were prisoners in Aurangzeb's camp. But every person fought for himself without waiting for an order from a commander, because the entire organizational structure had been destroyed by that. And this kind of a battle continued till the year 1700. For 8 long years, the fort of Jinji could not be captured by the Mughals. In 1700, Rajaram had come back to Maharashtra and he died here on the fort of Simagad. And his wife, Tarabai, she carried on the struggle with Aurangzeb for another 7 years. And by 1705, Aurangzeb had realized that not only has he lost the war, but he has also ruined the Mughal empire, because the entire treasury was bare by that time. The main source of income for the Mughals was the income from Bengal. And that entire income was expended in this war. And just like the Spanish ulcer is said to have ruined Napoleon, this battle in the Deccan is supposed to have ruined Aurangzeb. And in 1705, he came back to Ahmednagar, where he died in 1707. And his death, of course, led to another battle of succession. And his son, who was with him at that time, was Azam Shah. And he had to go and fight with his elder brother, who had come from Lahore, Bahadur Shah. And Bahadur Shah defeated and killed Azam Shah. The third brother, who was in Bijapur, Kambaksh, also was defeated and killed. And that time, Azam Shah, when he was on his way north, he released Shahu, the son of Sambhaji. The whole purpose of releasing him was that you had to have a divide in the Maratha forces, which even today you find it that there are 2 states, one is Satara and one at Kolhapur. So when Shahu came, a lot of people flocked to his standard, and you find that in 1708 he is crowned as the king at Satara, but he allows his aunt, Tarabai, who had given a very stiff fight to Aurangzeb for 7 long years, to continue with her rule from Kolhapur. And therefore we have these 2 houses of the Maratha royal family at that time. So this was what happened till 1707. Now 1707 is a watershed in Indian history, because the death of Aurangzeb kind of defines what happens after that. And a new scene opened in the Deccan after Shahu returned over here. After he crowned himself as the king at Satara, you find this man had been a prisoner in the Mughal camp for 18 long years. From the age of 7 till the age of 25, he had lived in the Mughal camp in fear of his life, in fear that at any moment the emperor might decide to change his faith, and he and his mother had to make sure that they survived it by all means. One person who helped them at this time was Aurangzeb's own daughter, Zinatul Nissa, who had a soft corner for this mother and son. And somehow, even when they were being forced to convert at that time, his daughter appealed to him that let them be. And in lieu of them, 2 sons of a chief, a senior chief of the Marathas was forced to convert. So in this way, he survived to the 18 years, and therefore he was not of a martial disposition. Shahu ruled from 1708 to 1749 when he died. But in 41 years, there is only one campaign recorded on his name, which he went into, and that too against his cousin, the king of Kolhapur. And in 1713, he was again threatened when the naval admiral, Kanoji Angre, climbed up the ghats, there's a fort called Rajmachi near Lonavala, captured that fort and threatened to come and march onto Satara and extinguishing Shahu's rule. Because Kanoji Angre was a loyalist of Tarabai. So he not only that, he captured the prime minister of Shahu and packed him off as a prisoner to Kulaba fort. So Balaji Vishwanath, who was a very loyal officer of Shahu, was appointed the Peshwa. And what we normally call as the Peshwas began with this Balaji Vishwanath in 1713. So he goes and meets Kanoji at Lohgad near Malauli. And he appeals to him that the Shahu is the real king, and therefore you must switch your loyalties to him. And whenever you are threatened by the Siddhi of Janjira, or you are threatened by the English or by the Portuguese, we will also come to your help. In this way, you find that the kingdom of Shahu suddenly reaches the sea, because Kanoji Angre joins him. Now again, the Mughal emperors who came after Aurangzeb were all ineffectual, weak emperors. In a matter of 12 years after Aurangzeb's death, you find in Delhi 6 emperors have changed hands. So his son died in 1712. One more chap, Jahandar Shah, came for 1 year. Farrukhsiyar came after that. And Farrukhsiyar was actually controlled by 2 brothers called the Sayyid brothers, one of whom, Hussain Ali, was appointed in the Deccan as the viceroy, the Mughal viceroy. Now this Hussain Ali wanted to unseat Farrukhsiyar because he found that the emperor was not favorable to them. So he sought help from the Marathas. And 30,000 strong Maratha army under Peshwa Balaji Vishwanath and Hussain Ali marched to Delhi. So within 12 years of Aurangzeb's death, you find a huge Maratha army actually taking over Delhi and changing the emperor and putting a puppet in his place. And in exchange, the Marathas get several rights to collect taxes in the Deccan. For having done this, Shahu's mother, who was in prison for 30 long years, is released and brought back to here. 1 year later, Balaji Vishwanath dies, and the era of Bajirao, as they call it, in 1720 begins for the next 20 years. And it was in Bajirao's time that the Maratha kingdom, which was still restricted to a small circumscribed area in the western part of India, actually becomes an empire. So let us see how he manages to do that. In 1724, the Nizam-ul-Mulk of Hyderabad, he decides that he's had enough of Delhi and he comes to the Deccan to form his own kingdom, autonomous kingdom in the south. And initially the Marathas help him. In fact, Bajirao helps Nizam Ali defeat the then viceroy of the Deccan in 1724. But soon they realize that the Nizam's motives are to take over the entire Deccan under his charge, to get rid of Shahu and put his own people in all these places. So in 1727, the Nizam comes marching towards Pune and he decides to capture Shahu and put him as a prisoner again. That is the time when Bajirao sends his younger brother Chimaji Appa with Shahu to the fort of Purandar as a safe place, and he enters the Nizam's territory instead of trying to defend Pune, which was that time just a small village. He tries to attack Aurangabad, he goes further to Jalna, he goes further to a place in Marathwada called Mangrul Pir. From there he heads to Burhanpur, and the Nizam is wondering what is his next move going to be. And then he goes to Gujarat. So the Nizam comes back to Pune, and then from Gujarat he comes after 2 or 3 months over there and makes a beeline straight for Aurangabad. So you find that the Nizam again coming out of Pune, crossing the Godavari to go and defend Aurangabad. But before the Nizam's artillery could cross the Godavari, the Marathas have completely encircled this chap, cut off all his food and water, and in 3 days the Nizam with his entire army is forced to surrender to Bajirao at a place called Palkhed near Aurangabad. And this victory over the senior most and most experienced Mughal general of the time is what actually takes Bajirao's name all over India. So, in fact, the Battle of Palkhed has been described by a very senior field marshal of the Second World War, Field Marshal Montgomery. In his book, he writes that the campaign of Palkhed, where Bajirao defeated the Nizam, can be called a masterpiece of strategic mobility. The way he moved is, and a purely cavalry-born force at that time. The very next year, Bajirao's brother Chimaji Appa entered Malwa. Now, Malwa is a province between the North Indian Hindustan and the South Indian Deccan, which is a bridge province. So it was very important strategically to hold it. And therefore, Chimaji Appa enters Malwa. There's a frontal battle with the Mughal governor named Giridhar Bahadur. He is killed at a place called Amjera in Madhya Pradesh. And the next year, you find that Bajirao heading towards Bundelkhand. The Bundelkhand was the kingdom of Chhatrasal. Chhatrasal was almost 80 years old at that time, but he was under attack by the Mughal governor Muhammad Khan Bangash, who was the governor of Allahabad province. So, from Bundelkhand, Chhatrasal sends an emissary to Bajirao with a letter. There are 4 lines in that letter in Bundeli language, which are very significant. He says, "So gat grah Gajendra ki, so gat bhai hai aaj. Baji rakh bule Bundelan ki, baji rakho laaj." There's a story in the Bhagavad Puran where an elephant is trapped, wherein the crocodile is holding on to its leg. And this Gajendra, as the elephant is called, prays to Lord Vishnu and asks him for help. And Vishnu comes down and rescues him from the crocodile by killing the crocodile. So he uses a similar kind of a metaphor to seek help from Bajirao by saying this. And Bajirao, of course, goes there, defeats Bangash. Chhatrasal is very pleased that Bajirao has helped him. 1/3 of Bundelkhand is given to Bajirao, along with Mastani. And had it not been for Mastani, we wouldn't have seen the movie Bajirao Mastani. So even the diamond mines of Panna, part of it are given to Bajirao at that time. But Malwa was not ceded by the Mughal king, Muhammad Shah Rangila. So Bajirao decides that if Malwa is not ceded to the Marathas, he will make a campaign and actually attack Delhi. Now Delhi as a capital of the Mughals had never seen an enemy at its doors from 1556 for almost 180 years. So Bajirao actually goes to Delhi. Well, there are 100,000 Mughal soldiers to the south of Delhi. He weaves his way through that and attacks Delhi. And people there are shocked that the Marathas have reached there. In fact, first they don't believe. The Mughal Darbar doesn't believe that the Marathas have come here. So they send a spy disguised as a beggar to find out whether the Marathas have really reached. First, Bajirao comes to the temple of Kalkaji in Delhi. It's a Ram Navami day. And he does some roughing up some people. He takes away some elephants and takes away some camels who had come there. And one spy who is dressed as a beggar comes to the Maratha camp. And at late night when he goes back to the Mughal Darbar, he shows the arms that he received as a beggar. So they are just dry gram and some dry bhakri. Bhakri is the roti which is made in Maharashtra. Just seeing the food which the Maratha trooper usually eats, the Mughals are convinced that Bajirao has reached Delhi. They try to send an army of 5,000 to defend the city, most of them are chased off or killed. And then before this 100,000 Mughal soldiers realize that Bajirao has slipped through them and reached Delhi, he slips away to Palam and then comes to Rajasthan and Kotputli. And then he writes to his brother later on that I could have burnt the city of Delhi if I wanted to. But Delhi is a Mahasthal, it's capital of India from ages. And burning the city would have broken the cord of diplomacy. So you don't find Bajirao coming across just a pure warrior or a military general, but he also is a bit of a statesman who doesn't indulge in unnecessary bloodshed, even whether it's defeating the Nizam or attacking Delhi. He doesn't want to shed blood to gain his objectives. War is ultimately diplomacy by other means. So that is one of the principles which he is following in all his battles which take place from that time onwards. And Malwa was ceded later on. In 1741, you find Malwa is ceded to the Marathas. So this is how the empire in those 20 years you find expanding. One letter at that time says that our realm has reached the Yamuna. Because when they captured Bundelkhand and Malwa, the Chambal and the Jamuna rivers were the northern boundary of the Marathas, which they crossed and went and attacked Delhi at that time. And in the south, their armies had already gone as far as Srirangapatnam, which is just near Mysore. So that's how the 20 years of Bajirao actually created this empire which you find later on. And then the most interesting part of this entire century is the time of Nana Sahib Peshwa, which are called extraordinary epoch, because so many things were going on at the same time. In 1740, you find Raghuji Bhosle of Nagpur going south as far as Trichinapalli, capturing the fort of Trichinapalli from the Nawab of Arcot. From there he comes back. During that time, the governor of Bihar, who is actually under the Nawab of Bengal, comes and kills his master and takes over the province of Bihar, Bengal and Orissa. His name is Ali Vardi Khan, who is called as an usurper in many texts of that time. So one of his officers comes running to Nagpur and tells Raghuji that please come to Bengal and rescue us from Ali Vardi Khan. And that is what actually sets off the Maratha invasion of Odisha and Bengal. And the demands of the Marathas are very simple. Odisha, of course, Raghuji Bhosle takes as under him. And he tells the Nawab that if you want to survive as the Nawab of Bengal, you have to pay us a chauth or a ransom or a tribute of 12 lakh rupees a year. In those days, 12 lakh rupees was a huge amount of money, which the Nawab initially refuses. And therefore, this battle between the Nawab of Bengal and the Marathas carries on for 10 years until finally 1751, you find Ali Vardi Khan conceding the demand and starting to pay his 12 lakh rupees to the Nagpur branch of the Marathas. So this part of growth, and Odisha of course remains in the Maratha Empire until 1803. Then the Nizam of Hyderabad was defeated several times in the 1750s. And in 1760, with Sadashivarao Bhau, the Peshwa's cousin, at the place called Udgir in Marathwada, a huge defeat at that time, and 4 important Mughal cities of Ahmednagar, Burhanpur, Daulatabad and Bijapur come under Maratha rule. And there are letters at that time that this is a time when the south has to be vacated. It is also the years when the Anglo-French rivalry kind of boils up in the Karnataka, on the Coromandel coast. And Dupleix, who is actually a visionary French governor of Pondicherry, he makes inroads and even takes over the Nizam's kingdom. He's got ambitions of capturing Bengal, taking on the Marathas and spreading the French Empire all over India. Unfortunately, the King of France, who is the patron of the French East India Company, doesn't support Dupleix, and therefore today we are speaking in English and not in French. But the main adversary for these 20 years, which you find, was none other than Ahmad Shah Abdali. Nadir Shah was assassinated in 1747 in his camp, and Ahmad Shah Abdali was once a servant of Nadir Shah. He gathers his own army around him, takes whatever treasure he can from Nadir Shah's tent, and he founds the kingdom of Afghanistan. Even today, you find Ahmad Shah Abdali is known as the father of Afghanistan. On Afghan banknotes, there's a picture of Ahmad Shah Abdali. So this state of Afghanistan is founded there, but it's a barren conquest. Afghanistan has got no income. It's a desert mostly. So he decides that the first place he can get money from is from the Punjab. And 1747, you find him attacking the Punjab. And the first battle is defeated by the governor there. 1748, he comes back, and this time he gains a victory. He comes to Lahore, takes a huge tribute and goes back. Now, in 1752, when Abdali comes back and sends his wakil to Delhi and demands that a further amount of tribute should be paid every year to me, the wazir at that time in Delhi is a man named Safdarjung. In Delhi, you have Safdarjung Airport, Safdarjung Tomb, and all these places. Now, this guy, Safdarjung, is the wazir, but he has just been defeated by the Rohillas. The Rohillas are actually immigrants from Afghanistan who are settled in Rohilkhand, north of the Ganga. So their loyalties still lie with their parent country, which is Afghanistan. So when they defeat the wazir comes to Holkar and Sindhia, who were in the north at that time, and tell them to help him. This is getting very complicated. I hope you are all able to grasp it at the speed at which I am telling you this, because I've got only 20 minutes to wind up the next 40 years. So you find that the wazir tells the Marathas that please sign a treaty with us, that you will protect the Mughal emperor from all his internal and external enemies. So you see the whole cycle has come a full circle. From being the main opponents of the Marathas, the Mughal emperor, who has become a puppet and sitting in Delhi, repeatedly being attacked by Ahmad Shah Abdali, is asking the Marathas to be the protector of Delhi and his own rule, which the Marathas accept that. And in exchange, he tells the Marathas, I will give you the Suba of Ajmer, I will give you the Suba of Agra, plus I will give you 30 lakh rupees for your service. So the Marathas take their offer, and that is how the Marathas take on this role of protecting Delhi from the invasions of Ahmad Shah Abdali. They keep a small army of about 5,000 people in Delhi to first face Abdali whenever he comes. And in 1757, Najib Khan, who is a Rohilla, he is the man who finds that the Marathas are very troublesome because they are coming to the north and interfering with us. The status which we once upon a time had in the city of Delhi has been completely downgraded. The Marathas are people who are calling the shots over here. We have become second-class citizens in Delhi. So he decided he will call his countryman, the king of Afghanistan, Ahmad Shah Abdali, once again to put the Marathas in their place. And that is what brings on the invasion of Ahmad Shah Abdali in 1757. And that is a time when Delhi is so thoroughly looted that even Nadir Shah's loot pales in comparison to the amount of loot which is taken from Delhi in 1757 by Ahmad Shah Abdali. The only two people who fight him are the 5,000 strong Maratha army at Delhi and Surajmal Jat, who is in Bharatpur. After finishing the loot of Delhi, in fact, one place I have mentioned it several times earlier, the loot is so voluminous, so humongous amount of loot is captured in Delhi that elephants, camels, horses, donkeys, every animal in the city is appropriated to carry the loot back to Kabul. To the extent one writer writes, even the washerman's donkey is not left behind. Even he is appropriated to carry the wealth back to Afghanistan. So that is the extent of loot. But Najib Khan didn't stop with that. He said, now that you've done this, you must go to Mathura and Vrindavan, where there are a lot of pilgrims and sadhus and bairagis and Gosawis, and you must go and attack them and kill them. So the next thing you find is that in February 1758, you find Abdali coming down to Mathura and indulging in a massive slaughter. And it is said the Yamuna river, the waters of the Yamuna ran red at that time. And this would have continued for longer, but for an epidemic of cholera which struck Abdali's camp, and hundreds of his people began dying every day. And therefore he had to hurriedly wind up and return to Delhi, take his entire loot and go back to Kabul. When he started back for Kabul, the Marathas got their army together. Raghunath Rao, who was at that time the general in the north, who was a brother of the Peshwa, and along with Mallara, Holkar and a few others, they entered the Punjab. And they captured most of the places in the Punjab, and then they entered Lahore. For the first time you find the Marathas entering Lahore. And the Abdali's son, Taimur Shah, and his general Jahan Khan fled across the river Ravi, which is to the west of Lahore. And from Lahore, almost 18 to 19 months, the Marathas were stationed in Lahore, controlling that part. And from there, they had sent their army to 3 other places. One is Attock, which is across the river Indus, Multan, and to Peshawar. So Lahore, Attock, Peshawar and Multan, 4 places were under the Maratha rule for almost 18 long months. And that time there was a very famous letter, which I don't know which I've got time to mention it, written by the Shah of Iran to Raghunath Rao, that let us do one thing, you come from the east and I will come from the west, and let us crush Ahmad Shah Abdali between our 2 forces. And Raghunath Rao writes to his brother, who is the Peshwa in Pune, the offer from Iran says that you take Kabul and I will take Kandahar. But he says, why should I give Kandahar to Iran? Because Kandahar has been part of India for centuries, as long back as the rule of Alamgir, Aurangzeb, it was part of the Mughal Empire. So why should I concede Kandahar to the Shah of Iran? So that plan fell through, and nobody expected that Abdali will make a comeback after that. So till the end of 1659, you find the Marathas well entrenched in these 4 places in Punjab and the northwest frontier province, right looking at the Khyber Pass. And then Najib Khan once again starts his moves to recruit Abdali and come to call him back to India. And Abdali recruits an army. He tells his army that you come with me to India, and what are the things you will get? He tells them you will get Zan, Zar and Zameen. Zan, you will get women. Zar, you will get gold. And Zameen, you will get land. So for these 3 things, accompany me and come to attack India with me. He gathers an army of 60,000 strong people, and from the Khyber and Bolan passes, comes into India, and the few 4,000-5,000 people sitting in Multan and Attock and Peshawar are easily wiped off. He takes over Lahore also, and he starts coming towards Delhi. That time Dattaji Scindia is responsible for looking after Delhi. And Najib Khan and Abdali have got together, and they are on the eastern bank of the Jamuna, while Dattaji Scindia is in Delhi, which is on the western bank of the Jamuna. And in 1760, the Makar Sankranti of that day, the forces of Najib Khan and Abdali start crossing the Jamuna in large numbers. And when Dattaji Shinde goes to fight with them with his troops, he is killed in that battle. And then Delhi passes into the hands of Abdali, and he decides on Najib Khan's pleading that don't go back to Afghanistan because the Marathas are sure to send a huge army from the Deccan to throw you out. So Abdali stays put. He doesn't go back in the summer as he normally does. And the Marathas, who had already won a huge battle in the south versus the Nizam in 1760, which I mentioned earlier, they decide to go north with a huge artillery and an army to confront Abdali and make sure he doesn't keep coming back. This is the 5th invasion Abdali has already come into India, and each time he has indulged in tremendous amount of cruelty and loot and that kind of thing. So 1760, March 1760 onwards, the long campaign from March 1760 to January 1761 is the campaign of Panipat actually. When Sadashivrao Bhau is nominated to lead the Maratha army, Ibrahim Khan Gardi, who's chief of the artillery, and a whole phalanx of Maratha chiefs come to the north. No other Indian ruler comes to join them in fighting Abdali. On the one hand, they are scared of Abdali. On the other hand, they also don't want the Marathas to come north. So finally, after capturing Delhi in July 1760 from Abdali's troops, they are short of cash. there is a royal family to feed. So the emperor has already run away to Allahabad. There's no emperor in Delhi at that time. There's no wazir in Delhi at that time. And after finishing the monsoon season, they head north to a place near Karnal called Kunjpura, where about 6,000 Afghans are waiting to cross the Jamuna after the floods of the Jamuna come down and join Abdali. So they attack Kunjpura. Those 5,000-6,000 Afghans are all cut down, and they get a huge amount of money, huge amount of food grains, which they are falling short of. Abdali, when he hears this, he crosses the Jamuna at Sonpat, Bagpat Sonpat, he crosses over, and he starts moving northwards. The Marathas move southwards towards Delhi, and they come face to face at Panipat on 31st of October 1760. For next 2.5 months, it's a battle of attrition, of trying to cut off each other's supplies. While from Delhi and Doab of the Ganga and Jamuna, Abdali continues to get his supplies from his allies, who are the Shuja of Awadh or the Rohilas. The Marathas are cut off from Delhi because Abdali is between them and Delhi. And at the end of 2 months, you find that starvation sets in the Maratha camp. And finally, they decide that we have to either go and fight rather than starving ourselves to death. And on 14th of January, they have a breakout from their camp, and they decide to go and attack Abdali. And the battle is so furious, starting at 9 a.m. in the morning, that till 2 p.m. in the afternoon, it almost appeared as the Marathas are going to win the battle, because the Afghan right wing and the center wing is completely destroyed, decimated by the Maratha attack, by the cavalry attack and the artillery attack by Ibrahim Khan Gardi. And that is a time when Abdali, in fact, fears that the Marathas might reach his camp, and he gets his Janan Khana mounted on elephants and camels so that they can be run away from there should the Marathas come close to his own camp. But then suddenly a bullet strikes Vishwas Rao, who's the son of the Peshwa, who's sitting on his elephant. And then these exhausted, starving Marathas, there's a sudden collapse, and they start fleeing that battlefield, trying to get back to Delhi. And the people who surrendered, Sadashirao Bhau is killed, Vishwas Rao is killed, the 2 main chiefs are killed, 27 other more important chiefs are killed. But most important was the people who surrendered, and the people who are the non-combatants are lined up, and they are their heads are cut off. And several prisoners are taken back along with them. And today in Baluchistan, for example, you find several tribes who put Maratha at the end of their names, because these are all people who were taken back by Abdali when he went back towards Kabul later on. Now Abdali, when he went back, it was a Pyrrhic victory. He never came back to Delhi after that, nor did he get any great amount of treasure from this. He told Najib Khan that you have swindled me by involving me in this battle where I have lost a lot of people too. And Nanasaheb Peshwa was already near Jhansi. He didn't want another battle on his hands. So he wrote to the Peshwa saying that I hand over the administration of Hindustan to you, and you can take care of it as you wish, and I am going back. The 4 more invasions which came from Abdali were all stopped by the Sikhs in Punjab. He never reached Delhi after that. But the real victors of this battle of Panipat were the English, because there's a power vacuum in the north. And the English from Bengal entered Bihar, captured Bihar. From Bihar they entered Awadh. They took charge of the places like Prayag, Allahabad Fort, Chunar Fort and Varanasi. So these places went into English hands, never to be recovered after that. So this is what happened because of Panipat, that the English became the ascendant power. And post Panipat there was a recovery which was led by Nanasaheb Peshwa, died within 6 months of the battle, and his son Madhav Rao on the left was the man who led the recovery in spite of opposition from his uncle Raghunath Rao. And in those 8 years or 11 years that Madhav Rao was the Peshwa, he recovered not only Delhi, but he defeated the Hyder Ali 4 times and till the gates of Srirangapatnam, had a huge tribute from him. And when he died at the age of 27 and a half, near Pune on Solapur Road, the place called Theur, he had taken the Marathas back to their pre-Panipat position. He not only captured Delhi in 1771 with Mahaji Shinde and Holkar and 2 other officers, but Shah Alam, the Mughal emperor who was in exile at Allahabad, was brought back and put back on the throne of the Mughals, and he promised to give them a lot of things which eventually did not, and therefore they had to be fought again. After Madhavarao recovered the whole thing, his younger brother, who was again only 17, Narayan Rao, became the Peshwa, and Raghoba, who was Raghunath Rao, who was the uncle, was asked to help him and guide him in his rule. But this was not to be. Because barely 9 months into Narayan Rao's rule, not only was an immature man who kind of hurt a lot of people, rubbed a lot of people the wrong way, but his uncle was overtly ambitious and he wanted to be the Peshwa himself. And over a period of time, the antagonization reached to such a limit that Narayan Rao is assassinated by the Gardis in his own palace. And that leads to a civil war, because there are the ministers and generals of the Marathas who don't like this, and they form a league to oppose Raghunath Rao. Raghunath Rao goes and joins the English, and his joining the English leads to the first Anglo-Maratha war, which goes on from 1775 to 1782. And at the end of the war, the Governor-General Warren Hastings is too tired. He is not able to get through anywhere. Hyder Ali has joined the Marathas in fighting the English in the Karnataka. And therefore, finally, the English decided that we must have a policy of peace with the Marathas. And Mahatji Shinde at this stage becomes the master of Delhi. Shah Alam is just a small puppet who is under his control. And practically from the 1780s till 1803, Delhi is ruled by Mahatji Scindia and his son Daulat Rao. And it was only, the government is not run by any Peshwa from that time onwards. It is run by ministers and generals. So Nana Fadnis at Pune and Mahatji Shinde in the north are the two people who are actually controlling the Maratha fortunes. What happens after that? In 1790, Tipu Sultan becomes too strong, and the English are unable to fight him individually. So they tie a treaty with the Marathas in 1790, and this is a palace which no longer exists inside the Shaniwarwada. So this scene shows the English ambassador to Pune, the resident, actually handing over the treaty to the Peshwa, and they form an alliance with the Nizam, the English and the Marathas, to fight with Tipu Sultan. This battle in 1791 leaves Tipu much weaker than what he was. It's a smaller area. And later on, in the last battle with the English in 1799, you find Tipu Sultan is killed. And that leaves the Marathas not only surrounded by the English power on all four sides, but they are the only power left at that stage. The Peshwa who was appointed at that time is the son of Raghunath Rao, Bajirao II. Now this man has got no military power, no military training, no power of his own. He's put there as a puppet by Daulat Rao Scindia. And the Scindias and Holkars are not getting along with each other. In fact, very close by, just across the Bhairova Nala, a huge battle takes place in 1802, where the Scindia forces and the Peshwa's forces are defeated by Yashwantrao Holkar. That's called the Battle of Hadapsar. And because of that, the Peshwa flees from Pune, and the English follow him to Vasai, where he realizes that if he has to become the Peshwa again, he needs the help of the English. And he signs the subsidiary treaty, effectively ending his own independence. Though he becomes the Peshwa after that, he is continuously a puppet of the English. So the real power of the Marathas is finished by the Second Anglo-Maratha War between 1803 and 1805. And then you come to the end. Like every empire, I say, has got a shelf life, and the end was near. And this picture is a picture of the Battle of Khadki near Pune. And this is taken from the English side. So you find that there is an English square in the front, and they are surrounded from all sides by Maratha horsemen trying to attack them. And the guns are being fired by the English at them. And this battle, which took place on the 5th of November 1817, Third Anglo-Maratha War, which is actually started by the Peshwa to try and overthrow the English. Very ambitious venture at that stage, where the English were completely in control. And the battle continues, the war continues for almost 7 to 8 months at that time. But the Peshwa finally has to surrender. He's pensioned off to a place called Bithur near Kanpur, where he stays for the rest of his days at a yearly pension of 8 lakh rupees. Now this picture is very significant because the British Empire in India started from the Battle of Khadki. So this picture was in the British Foreign and Commonwealth Office, a huge picture, it's about 10 feet wide, to show any visitor to the Foreign Office that this is our empire and we started our empire from this battle. Today, the Pune University is where this battlefield lies, Battle of Khadki. And when the Peshwa settles down in Bithur as a pensioner, the four people who we were just speaking about it some time back, the four people who actually are with him in his household, growing up in his household, are Nana Sahib, Rao Sahib, both his adopted children, Rani of Jhansi, Lakshmi Bai, and Tatya Tope. And these are the four heroes who eventually take on the British in the War of 1857-58, and which actually are the main fighting force against the English in the 1857 war. Now, what is the importance of this Maratha century as I titled this talk? It falls between the Mughal and the English powers. Very often in history books you find the Mughals are there and then they give way to the English, which is not the case. Not only that, after 4 centuries of Turco-Persian Afghan rule, this is the first indigenous empire in India, the Marathas, for 150 years or so. And also it is the last indigenous empire before once again you are subjected to becoming a colony of Britain. So the legacy of the Marathas is not only the regaining of the independence and the political power by an indigenous power, but it's also a renaissance of Indian cultural values, which had, for example, if you go to places like Maheshwar or Kashi or Ujjain or even temples around Pune, most of these structures have been erected in the 18th century or late 17th century. And this entire cultural renaissance which took place in those 150 years was because of this entire period, that 150 year long, which was set off by the Swarajya, which was dreamed of by Chhatrapati Shivaji at that time. I realize I'm out of time, but the story is over. 1818 is the time when the English take over. And I hope that I have given you some food for thought, and when you go back, at least you Google for what the real story is. And I must thank AFMC to invite me over, and I must invite all my young friends here for a patient listening. And I hope that I have done some justice to the topic. Thanks a lot.
Thank you so much, sir. Not only did the British Empire start off in at the Battle of Khadki, but in some ways it set into motion a series of events that eventually landed us, for AFMC to be created where we are today. So in some ways, your beautiful talk has sort of linked us to the momentous events of that particular era. It has been a fascinating talk by you, sir. I will request if there are anybody who have any questions, I will of course interrogate you later, sir. Anyone from the audience would like to ask her a question? Yes, Colonel Praful.
Is there a mic?
Such a concentrated aliquot of history, sir. So one thing I've always wanted to ask you was that we see large swaths of land exchanging hands very frequently between different rulers. And barring the Persian influence and the British influence on the way we eat, talk and dress ourselves, otherwise, irrespective of the fact that land has been exchanging hands, we still find that the regional identities have been largely preserved. So something which is Tamil remains Tamil, something which is in the sense Punjabi remains Punjabi, irrespective of the fact that so many rulers have ruled over that land over a large period of time. So what in your opinion is something which sustains that traditional way of life, number one. Number two, sir, how do you see the role of religion in these later conflicts in the modern Indian history, sir? Unfortunately, it's becoming increasingly politically incorrect to talk about history and religion. So was it religion ab initio and the root cause of all that was happening, or it was just a serendipitous association, sir, if I may ask that?
Actually, it's a mixture of both, because it started off as a reaction to religious oppression. Started off with that. But once somebody comes in power corrupts, And over a period of time, it's not just the religious aspect which has to be tackled, but also profit motive. So if you're sustaining an army, if you're looking after the army, you need funds for that. And you also need sustenance for your own treasury. So when you go to a land which is, the battles which took place were not necessarily, suppose the Marathas are going to Punjab or Bengal, they were not against the Bengalis. It was basically against the ruler who was ruling that region. And in modern parlance, for example, suppose you want to harass somebody from another department, and that person is, the HOD is, you don't like that guy. So his subordinate, you kind of trouble him with several things. So eventually, indirectly, you're troubling the ruler there. So these things happened even at that time. Now, as far as the identity of each region is concerned, communications were never very good, even in those days. So it was not that the large-scale exchange of population, the way people are traveling up and down now, for them to forget their identity. You find people who come to work in Maharashtra today learn a smattering of Marathi, at least a few words enter their vocabulary. So I suppose that is happening more now. And even this entire thing of caste, you find it as successive generations are, you find somebody's son has married a Chinese national, settled in USA, was working there, found a Taiwanese girl or a Chinese girl and married her. These instances are becoming more and more frequent nowadays. So that identity will remain with you for some more time. Of course, I'm not saying that we should all become kind of homogenized and mongrelized. You have a right to preserve your own identity, and that is an inherent human nature. I mean, I would say that human nature is when you meet a person, first thing you see is what is different between him and you. And that goes across the entire spectrum of your identity and the person whom you are meeting. So I think you cannot take human nature out of the human being, because we are not yet machines. So the same thing that happened in the 18th century today happens, but we sanitize it, or we try to put a cover on it. But it exists because we are still organic human beings.
Thank you, sir. Thank you very much. And on behalf of the organizers and the entire college, I once again thank you for your excellent exposition, sir. And I request you to kindly accept a memento from the Commandant's side. To the Commandant. Yeah.
What a powerful journey through history that was. A huge thank you to our guest speaker for breathing life into the legacy of the Maratha Empire with insight, passion, and storytelling that truly captivated us all. A salute to your brilliance, sir.
We will now be taking a break for 5 minutes so as to arrange the stage for the next event. Delegates and cadets are requested to remain seated as we will be resuming shortly.
Check, 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 check. Check. Check, 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 check.
We will now have the finals of the Onco Quest, the medical oncology quiz. The prelims of the quiz were held yesterday, after which the top 4 teams out of a total of 13 teams qualified for the finals. The 4 teams are as follows: a team from Gandhi Medical College, Hyderabad, consisting of Abhishek Dwivedi; a team from Swami Ramanand Tirth Rural Government College, consisting of Maitri Gowde and Diksha Godara; a team from ACMS Delhi, consisting of Shubham Singh and Aditya Vishnoi; and a team from AFMC, consisting of Ujjwal Singh, Manish Sharma, Ankit Kumar Yadav. All teams are requested to come up on the stage.
We would now like to invite on stage the quiz master for today, Lieutenant Colonel V.S. Prakash, who is an oncologist of high repute with great human touch which stays in the heart of his patients. Over to you, sir.
Thank you, everybody. Let's start the quiz. So, as you can see, the rules of the quiz are, I'm the boss. It's answered on the, say, a visual or something, you get 30 marks. If it's answered in second clue, you get 20 marks. And for every other thing, if the team is not able to answer, what we do is we write on a piece of paper so that there is no, nobody gets an unfair advantage, right? So you write it on a piece of paper, hand it over to one of the students who's standing beside you, and then they'll come and give me the check. So what happens is, I'll see, and in case your answers are found correct, you gain 10 marks out of it, right? Any other questions, any queries from your side? Or shall we go ahead? My audio questions. Yeah? So shall we? There's no buzzer round and all. So feel relaxed. You have 10 seconds to answer each question, right? So we'll start from team A. Your questions. So this is a round which I thought would deal mostly with the events which have happened or shaped oncology in the past. So identify this British physician pathologist. Team A, the question is to you. You don't have to write. In case you know the answer, please tell. Or please speak on the mic. Rudolf Virchow. Okay, not exactly. So in 1870s, he wrote a treatise titled Some Morbid Appearances of Absorbent Glands and Spleen. His name is almost reminiscent with the way we deal with malignancies today. Team A, any takers? If anybody else knows the answer, kindly write it on a and throw it to the students at the back. The answer is coming from Team C. They've written as Sir Hodgkin. So I'll give it to you. It's not Sir Hodgkin, it is Thomas Hodgkin. Absolutely right. He is the one who, after his treatise, people went on, people researched back, and they found out that these absorbent glands, what were referred to as the lymph glands, right? And these lymph glands were later on referred to as lymphomas, the disease of lymph nodes, right? So we have this classification of lymphomas wherein the Hodgkin's and the non-Hodgkin's lymphomas are two classifications, right? So all the good lymphomas came to be known as Hodgkin's lymphomas, and all the not so good lymphomas which are difficult to diagnose, who did not have B symptoms, who did not follow a distinct pattern of spread, came to be called as non-Hodgkin's lymphomas. So next question. So they get 10 points. Team C gets 10 points. So he is a Greek physician come pathologist. His contribution to the field of malignancy has not been replicated till now, especially with respect to malignancies related to females. Identify the Greek physician. So he invented a particular kind of test which was used to diagnose. Please go ahead. Absolutely, very good. So the name of the doctor was Dr. Gregorios Papanicolaou, and he invented a method of staining vaginal and cervical mucosal fluid, which depended on, which changed from in menstrual cycles. So he made an attempt, and he proved subsequently that the way these vaginal cells would actually change, he could actually find out abnormal cells. And this is how he revolutionized a easier way of diagnosing vaginal, abs and cervical cancers, right? So the answer is absolutely right, Dr. Gregorios Papanicolaou. So they get 20 points. So this British physician, his name is almost synonymous to lymphomas, if I can say, and the individual extensively toured the continent of Africa, wherein he is supposed to have diagnosed a very fast-growing variant of lymphomas. Do you know the answer? So he found out that in children they presented specifically with jaw swellings.
Sir, Dr. Burkitt.
Okay, that's right. So the answer is Dr. Dennis Parson Burkitt. So these children, they generally would present as jaw swellings. Generally in the African subcontinents, Burkitt's lymphomas would present primarily with jaw swellings, but in the Asian and the other the Caucasian population, they would present specific with abdominal swellings, which are fast-growing neoplasms, right? So good. So Dr. Dennis Parson Burkitt is the answer. Next, Team D. Identify the lady. They get 20 points. Yeah, Team D. Identify the lady. She's a British chemist and is aptly termed the wrong heroine. So, she actually, the photo was taken by a colleague. The photo on the left was taken by a colleague, and why she was wronged was the two guys in the left had taken most of the credit for her discovery. So you don't know the answer? So anybody else? If people know, please pass it on the chits to the people at the back. That this is by team B. Okay. Okay. First class. Your answer? No answers? So I've received an answer from team B. They say it is Dr. Rosalind Franklin. Absolutely right. So Dr. Rosalind Franklin was a chemist, X-ray crystallographer from UK, and apparently in the year that Watson Crick actually went on with a seminal paper in Nature, illustrating what they said was the double helical model of DNA. They received the paper from, in the same year, same time, Nature receives 3 papers, and one of them happens to be of Dr. Rosalind Franklin. In fact, she is the one who elucidated the exact nature of the DNA double helix, right? And the photo that was flashed alongside was the photo that was taken by her. And this photo was, in fact, later on, Watson Crick also accepted that this photo formed the basis of how they could actually come across with their own assumption of the helical structure, double helical structure of DNA. So 10 points to them. No, there's no, I never said any negative marking. So we've got some audience, I believe. So this question is open to everybody in the audience, including Professor Uday, if I may say. So this photo depicts the nightmare in Bari. Please don't use any smartphone devices. That's the only thing that not to be used. So Bari is a small town in the Adriatic, Italy, which was apparently bombed. And in 1944, if I'm not mistaken, and there was a gas disaster, poison gas disaster. And what is the linkage of the poison gas disaster to these two individuals? It was called as the mini Pearl Harbor. 37 ships were sunk by the German Luftwaffe. So what the history that goes is, nobody from the audience. So the history that goes is, these two individuals, the cause of the bombing, because of the bombing, what happened was the allies, that is the US and the allies, had stored stockpiles of sulfur mustard gas in the Bari, which was apparently presumed to be non-bombable port in the Adriatic. So ultimately, since it was bombed, there are so many soldiers who got exposed to sulfur mustard gas poisoning, and subsequently showed signs of lymphocytopenias, and they succumbed to this malignancy. Yes? So this was the anti-cancer drug, but the fact is, these two individuals are Sloan and Kettering, right? Absolutely. So, very good. So, MSKCC, absolutely. So, these two individuals were contacted by the US government to set up a hospital, already running Memorial Hospital in New York. And Sloan and Kettering, they were from General Motors, and they were they had a contributed at that time a sum of money towards maintaining this hospital, and hence the name Memorial Sloan Kettering, right? And this is how we get out of a disaster, we get to know, we get a drug. Subsequently, this drug was synthesized, and we get the first, one of the first earliest anti-cancer agents that was synthesized. So that is the Memorial Sloan Kettering. It has got, this is taken from one of these offshoot branches. So let's come to round 2. Before that, I'll request the scores to be displayed. So after round 1, team B and C both are tied at 30 points each, and A and D are yet to open their scores. So we'll go on to round 2. May of 2000, please, yeah, May of 2001. There's this drug which hits the market, which is apparently called the magic bullet. A lot of uproar. It actually revolutionized the way we are dealing with malignancies today. It converted a hitherto disease which was, sorry, my mistake. Sir, you get the answer, yeah. You get to say the answer. You know the answer? Yeah, aapka hai. So they've got the mics. You know the drug? So it starts from D. You want to take the answer? You don't want to take the question? Okay, you thought it will again start from team. Okay. You want to still take the question? So this Times magazine cover highlights the way a path-breaking drug was, synthesized and started on with respect to one of the most dreaded malignancies the mankind had seen till that time. And now, most oncologists and hematologists do not consider this malignancy worth treating also. They say it's become a chronic disease. Okay? So team B, the question is still to you. I'll shift. So this is the karyotype of the individual who would be suffering from that kind of disease.
Would that be imatinib?
Yeah, the drug is imatinib, absolutely right. So how does imatinib work here? And what is this?
It's a translocation of chromosome 9 and 22. Philadelphia chromosome.
Absolutely, it's a reciprocal translocation. So what is it called?
Tyrosine kinase inhibitor.
Okay, the drug imatinib is a tyrosine kinase inhibitor. Reciprocal translocation leads to the formation of something called as Philadelphia chromosome, BCR. So which one of them is Philadelphia chromosome, 9 or 22?
BCR 22.
Okay, fantastic, very good. He gets 20 marks. So, that's his question is already there, no? But anyways, the answer is wrong. Don't worry. So, team C, a revolutionary drug reaches the market in 2007. It was almost, the research and all completed in early 1998, 1999 and reached and is already in use. But by 2009, its other uses are found, and it's going to revolutionize the way people are treating breast cancers. That's how it is. That's what is reflected there. So, are you aware of this drug? Okay.
Sir, is it trastuzumab?
Absolutely, very good. So that is trastuzumab, and the kind of targeting that it used to do was, it was called as HER2 targeting, right? So all these drugs that are there, trastuzumab was also reflected there. The other drug that was there is pertuzumab, margetuximab, and a host of these drugs, right? So these have changed the way we are looking at carcinoma breast. So the ladies, just plain simple, what is the Angelina effect? May 2013.
She encouraged other women to self-test for breast cancer.
Okay.
And to perform preventive mastectomies.
Excellent, very good. So, so she gets 30 marks for the same. So, what is it? What is the why does she encourage people to go out for say prophylactic mastectomies?
I think she had a BRCA one or two. I'm not sure.
Very good. So, what is to be highlighted is those ladies who have got a genetic tendency with respect to BRCA1 and 2, they've got an increased chances of having malignancy. In Angelina's family ran an entire series of patients who had BRCA positivity, and since she thought it is better to get prophylactic mastectomy done than go ahead with the rigors of the malignancy and subsequently the therapy. So excellent. So this is I wanted to highlight the sequencing and all. So yeah, so this kid got the Kid of the Year award in 2024. What is the award, name of the kid, and what did he do basically? Times Kid of the Year 2024. So the next, once the 10 seconds, so the next clue to this is, he pioneered a form of therapy designed by a routinely used agent to increase the drug's availability in the body, right? So what did he design, and what therapy, what kind of cancer is he dealing with? Anybody? If nobody, then I'll get ahead with the question or the answer. So this gentleman, he designed a soap, a soap with the help of 3M technologies, and he postulated that the anti-cancer drug delivery could be enhanced specifically in patients who had skin cancer. So for this discovery, he was nominated as the Times Kid of the Year 2024, right? So we'll go ahead with the audience question. Identify the individual in question. Anybody? Okay. Somebody else? Other colleges? Anybody else knows about this individual? Well, there's one hint I can say, that he happened to walk on the same, the hallways and all. So he is a graduate from the Armed Forces Medical College. Yeah, please. Anybody else? Okay. The name is Maharaj Kishan Bhan, Dr. Maharaj Kishan Bhan. And his claim to fame, Dr. Maharaj Kishan Bhan is the individual who invented the rotavirus vaccine. And what is why get his question here? So the individual actually happened to succumb to colon cancer. In fact, I had the, you can say, the opportunity of having been in the treating team when he was getting treated in the All India Institute in 2020. So we'll go back to the next question. So this is a bedside clinic. Scores, yeah, please. So at the end of round 2, we've got team B and C again tied up on 60 and 60, and team D has opened the account at 20. So let's move on to round 3. So what we need to do in round 3 is we correlate the pictures to arrive at a malignancy. I just want you to name the malignancy. And if you can tell the correlation, so if you only tell the malignancy, it is 20 points. If you tell the correlation also, it is 30 points. Understand? Right? If you only tell the malignancy, it is 20 points. If you tell the correlation also, it is 30 points. So team A, it starts with you.
Cholangiocarcinoma.
Okay. And what is the correlation?
So this is a worm which infests the biliary duct and causes chronic irritation, which can manifest in cholangiocarcinomas and hepatic carcinoma.
Okay. Very good. Good guess. In case others know the answers, please write it down.
Schistosoma hematoma.
I never said anything. So please write the answer in case people know. Both the things have to be written. So you write the okay. If you can tell the correlation also, I'll be fine.
So this is bladder carcinoma.
Bladder, which bladder?
Urinary bladder carcinoma.
Urinary bladder cancer.
And this is a picture of the schistosoma hematoma, male and female. The female is the thinner one.
No, that's okay.
And
but
then,
what is the correlation to the other photo?
So
what is the other photo representing?
it's a pyramid in the pyramid of the.
Okay, where is pyramid located?
Egypt.
So okay, so I'll give that to you. The correlation still could not be established, but schistosomia is one of the Egypt harbors almost 70% of the world schistosomia, and schistosomia hematobium is what is the parasite in question, right? And it definitely causes bladder cancer, right? Thank you. So he gets 20 points. So team B. Yeah, I think time is over. Would like to attempt? There's no problem with attempting, there's no negative marking. And in case others know the answer, please write it on a piece of paper, check, and send it back. No attempts from team B? No guesses? So what would you like to take? At least a guess? Which cancer, there's only a malignancy that you have to guess. If your answer is right, you get 20 points. So no, teams C ka le lo, check. No, team A? No. Anybody from the audience? The malignancy in question and correlation. So as you can see, the first photo is of an alpaca or llamas. Where are they found? They found in the Andes, right? They found in Andes. And the other photo in question is Everybody knows Bada Imambara is located in Lucknow. So the correlation here is both are one of the strongest places where you see gallbladder cancers. In fact, the Indo-Gangetic plain is considered the most important, the incidence of gallbladder cancer is the maximum, and so is the Indian Heights. So if you have to name one malignancy, it is the carcinoma gallbladder. Gone are the days when we used to recite the aphorism, fat, 40, fertile female, right? Right? So that aphorism has actually gone, in the back burner. We're seeing far more carcinoma gallbladders in the Indo-Gangetic plain. So team C, when was the last time you saw a football match? So the correlation between two, what does FCB represent? Kya? Which I just want to know the name of the malignancy, that's it. Even if you can scribble it on a piece of paper, the correlation can be done later on. Yeah, please. Your time is up.
Sir, is it pancreatic cancer?
Okay, and what is the correlation?
Sir, Cullen sign is
Cullen sign?
periumbilical swelling and inflammation.
Okay.
Indicating chronic
Very good,
injury
very good.
and
Very good.
inflammation. Cullen
Unfortunately, that's not the right answer. Team B, I have not got a check. You don't want to give any guesses also? Take a guess at least. Because I've got one check. And in case team A can tell the correlation also.
So I
Yeah,
guess
एक minute, just one. One sec. Yeah. Okay, fantastic. So I've got an answer from team A as hepatocellular carcinoma, and answer from team B as familial adenopolyposis. Okay. So the answer from team A is absolutely right. It is hepatocellular carcinoma. What is the correlation? Can you tell me?
So because hepatocellular carcinoma will lead to portal hypertension, and then these esophageal varices.
Absolutely. These are caput medusae, right? So these are signs of portal hypertension, right? And what is the correlation to FC Barcelona?
I don't watch.
So you don't watch. No, you don't have to watch football to know the correlation. In liver cancer, we use these common staging as Barcelona staging, right? So that is how you actually know how to treat liver cancers. So that's the correlation, right? So they get 20 points for identifying the malignancy correctly. Yeah. Team A. Team A.
Hodgkin's
Team
lymphoma.
Team D, yeah. Hodgkin's lymphoma, fantastic, very good. So what is the correlation?
Is that LD? Sorry, sir, is that LD lymphocyte depleted?
No, what is the correlation between the two? What is Lugano and Hodgkin's lymphoma?
No, the logo looks like LD lymphocytic depletion.
No, it is, no, just write Lugano, FC Lugano something. So, if anybody knows Hodgkin's lymphoma, the correlation between, yeah. You just write on a piece of paper, that's it. Okay. The correlation, I just want the correlation. The answer is given by him. Yeah. Just scribble it on a piece of paper, give it to. What is this written? So, the staging of, the earlier staging of lymphomas and lymphomas was based on a place called as the Ann Arbor. Now it is based on a place called as Lugano in Switzerland, right? So Ann Arbor staging, everybody knows, right? So Ann Arbor staging, Ann Arbor is a place in Michigan where the first time all the lymphoma and hematologist specialists, they attended the conference and they went on to go ahead with the staging, right? So these are spotters. I just want you to identify. Team D starts first. Okay, points. Team D gets 20 points. D. So next, please flash the scores. So, team B and C are tied up at 60 and team A and D are tied up at 40. So we move on to the next. I just want you to name the condition. Each person who names the condition correctly gets 30 points. On any, if you name the condition, even if it passed to you, it's fine. If it is only passed to you and you name the condition, the question ends there. If you are answering it on a pass and you're able to name the condition correctly, you get 30 points. Understand? Just pass it on a sheet of paper. Don't spell it out, right? So, starts with team D there. You got 10 seconds to answer this question. I won't give you a second more. If not, please scribble it on a piece of paper and give it. Yeah, ladies? Yeah? Time's up. You don't want to answer? You answer? Fantastic. Very good. So the other people are redundant. Yeah, thanks. Yeah, team B. No, you don't have to answer, no? Team B. Team C, sorry. Team D, team C. Team C, you write it on a piece of paper. You don't have an answer. Yeah, team C. No? Yeah, the girls here. Okay. So, team C is not able to answer. Yeah, I've got one chit, and that too from team D. The answer the gentleman has given is lesser trellat, CA stomach. Absolutely right. It is called as a sign of lesser trellat. Right? These are all peripheral markers of malignancy. We are supposed to start recognizing them. Right? So this is seen in. So he gets 30 points. Team B. Just identify the spotter. Yeah, ladies, your time is up. Yeah. A, team A? Yeah, ma'am.
Marjolines also.
Okay. So, that's not the right answer. Team A has not given me any answer, and they're not giving also. So, I've got one answer, one sheet from team D. It says Sister Mary Joseph. Well, that's the right answer. Sister Mary Joseph's nodule is a marker of pancreatic malignancy, right? So team B gets 30 points. Team A, that's the question to you. Direct question. So I just want you to name the sign. I just don't want you to name any condition. So the time's up. All please send your chits in case you do want to answer. So team A is not answering. So it's something to do with the palms. Okay. So it is called as your chits I've got. No, that's not right. See, I've got your chit. That's okay. The answer is tripe palms. I don't think you would have written that. So No, that's not acral melanoma. So that is called as tripe palms. So in malignancies of the lung and all, you tend to see this blackish, velvety discoloration of the hands, especially palms and soles that you encounter, right? So the audience question, I can see a few quizzes here. So the question to the audience is, connect the two dots. So there's a neck, I can't even say the bust, the neck of, shall I say, a Greek god, showing two heads and some reddish discoloration in the palms. Janeway lesions, not exactly. Yeah, so somebody in the audience is wanting to answer. Please, sir. Absolutely right. So how does polycythemia give rise to red palms? What is this condition called? Okay, fantastic. He still deserves a chocolate. So what this condition is called is, erythromelalgia. The neck or the neck in portion is of a Greek god called as Janus. So Janus is called as a god of the startings and the endings. That is why in the Gregorian calendar, the first month is January. So he's the god of starting and he's the god of finishing. So I've just round 5. Before we head down to round 5, just want the scores to be put up. At least people need to start sending the chits back so that you at least make a guess. Not writing anything because there's no negative marking. So at the end of round 4, we've Team D at 130, Team B and C at 60, and Team A at 40. So these are hematology spotters. I just want you to identify the condition. You identify the condition, you get 30 points, and that's it. In case you identify it if you identify it on the time I ask you the question. So I think Team D is the one, Team A. Okay. So Team A, identify the malignancy, the condition.
Or rod in AML.
Absolutely right. Or rod's AML. So he gets 30 points. Team B, the straight question to you. Okay, what is the characteristic finding? I want you to tell.
Smudge cell.
Smudge cell is the characteristic finding. I'll still give it to her because I wanted the characteristic finding. But CML does not have smudge cells.
I said CLL.
Okay, you said CLL.
Yes.
I'm so sorry, I heard it wrongly. Absolutely right. What happens? Yeah, the 30 points. So what happens in CLL, when you're preparing the slides, these are preparation artifacts. These are smudge cells, absolutely right. So cells are fragile and they tend to break. Team C, direct question to you. I just want you to identify the disease. Team C, I want you to identify a disease.
Sir, acute lymphoblastic leukemia.
Huh?
Acute lymphoblastic leukemia.
Okay. Ladies, just the disease. Find something at least. Then I just want you, I wanted to identify disease. What condition? So I think time's up. You can pass on a check. So I've got 3 answers, A, D and B. All 3 have answered it rightly as CML. So only team that had a direct question did not answer it. So all 3 get 30 points each. The team C, you have to identify, when your marrow starts looking, when your peripheral blood starts looking like your marrow, that's the time when you start saying that it is chronic myeloid leukemia. Understand? When your peripheral blood starts looking like your bone marrow. So the next question is to team D. I just want you to identify the disease. Identify the disease. The lady is, yeah. I think your 10 seconds were over, but I still want team C, nuances.
Hairy cell leukemia.
Very good. Team C, you answer? I just want, no? Thank you. So I've received 2 chits. Team A and Team B, they have identified it as multiple myeloma, which happens to be the right answer. So Team A and B get. So what is or the patient in reference has? He's got an altered sensorium, irrelevant talk and abdominal pain. So what are these manifestations of? Why do you think in terms of multiple myeloma?
A lot of plasma cells.
Very good, excellent. But what the manifestation was? It was manifestation of hypercalcemia.
Yeah,
right?
the crab.
Right? So any which ways, both of them get 30 marks each. At the outset, we would like to thank our sponsors, Pfizer, for the event. I don't think we would be requiring a tiebreaker here. I'll request the quizmaster to actually go ahead with the scores. Yeah, okay. You want an audience question? Okay. So identify these 2 people. Anybody who gets 3 chocolates. Their contribution to steam engines is irreplaceable. I said steam engines is irreplaceable. So we've got the final scores. Team D, a single man team, has actually won the quiz with 160 points. B and Team B, the ladies have come second with 150 points, and Team A has come third with 130 points. So very tight finish. The ladies actually, and they buckled up in the last, I think, the last round. One-man team has actually won the competition. You know, congratulations. Thank you. Prizes bar? Okay. Prizes will be given as per the announced prizes and would be given after the valedictory function. So please collect the prizes of winners. Congratulations. Thank you.
And that's a wrap on OncoQuest. A huge thank you to our incredible quizmaster for steering this intense edge of the seat showdown with such flair. From tricky turnarounds to time battles, this quiz had us all hooked till the last second. What a show. Delegates are to note that the awards will be presented during the valedictory ceremony at 2 p.m.
We shall now break for lunch. The delegates are kindly requested to move towards the Grove, which is just opposite to the main building on the left-hand side. The winners of the OncoQuest are requested to come to the stage and submit their names.